Пані та панове, тепер уже точно час займати місця в
Ladies and
залі.
gentlemen, this is time to take your seats. Just a few minutes and we will be starting. Thank you.
Доброго ранку.
Good morning.
Доброго ранку, шановні пані та
Good
панове.
morning, dear ladies and gentlemen. Welcome everybody who is in the Parkway and everybody who's with us online. There's a lot of us, and this is a great encouragement. My name is Timur Miroshnichenko, and I will be with you during these 2 days in such a great, wonderful atmosphere. But we do have to work fruitfully. And before we start, let's just put a bit of applause for everybody here, even if you're not physically present, even if you're remotely here. We are all moving together. I want to welcome every one of you here. It's nice to see this number of people here in the hall. And as I mentioned before, there's plenty of you online. Today in this space, we do have all of you present, the representatives of the state institution, international partners, medical community, civil society organization, and communities gather here. And this set of participants is showing us that around the topic of health, the community is working together, and such a strong community is working to bring the healthcare system closer and closer and more accessible and more understandable to every person. And such a video that we've seen at the beginning, I feel like it represents well the experience that a lot of people are going through when a person is left alone, even when the help formally exists. And that's why we are here today. This conference is about the pathway from screening to treatment, and not just the test itself or the risk definition, but it's more so what happens next: referrals, follow up, and most importantly, the interaction between the services and the trust to the system. And the most important part about the person that's not supposed to be left alone on the way. Before we start, there's a few organizational points that I'd like to mention. In this space where we are located, you can see a photo exhibition, and I think that a lot of you before the beginning started to look at this. Those are the stories of communities from different parts of Ukraine. Those are stories of the people, of the teams and solutions that are working on the local levels. And would like to advise you to look at them. Moreover, if you're located online with us, you'll be able to see this photo exhibition. Just stay with us till the end. Also, during these 2 days, from time to time, you will see a short interactive questions and QR codes for answers. So a bit later, when we'll be going through the active participation and questioning and answers, you just need to scan them, answer short questions, and then in such a way, we are involving all of you, whether you're online, offline, to an interactive part. And tomorrow, at the end of the second day, we will recognize the most active participants among the people present offline and among the people present online. And we will also give you a wonderful gifts. Therefore, I urge you to be active, to participate in all of those interactive parts that we will be proposing to you. Therefore, in any case, take your phones with you. You can always note down, video record, and also participate in our interactive parts and to receive gifts. For our online participants, we also have interpretation and sign language. For us, it's important for this conference to be a space for participation where every one of you will be able to be heard, listened to, and have an access to the content of what we are saying. So those are like the main organizational parts. So I think that we are ready to start. Once again, thank you all so much for everybody who's here with us. Thank you. Before I continue, I would like to say thank you for our protectors, defenders. Because of them, we have this wonderful opportunity to be here today. We have the ability to think, feel, dream, and plan and act on the health and the support for the communities and about our future of our country. And we do remember each and every one of them who've given their lives for us, for our country, for our freedom. So let's think with gratitude for those of us who are protecting others, and let's honor them with the moment of silence for everybody who died for all of us. So please stand up for the minute of silence.
Дякуємо.
Thank
Слава
you.
Україні!
Glory to Ukraine.
Ви знаєте, пані та панове, те, що ми
Ladies and
сьогодні з
gentlemen,
вами
the fact that we are all
розмовляємо, це
here
частина
present
спільної роботи
today, this is
для
a part of the
майбутнього
enduring
України,
contribution
для
for the
селян
future
і
Ukraine,
громад,
for
доступної
stronger
допомоги
community, more
і для
accessible
людей,
care,
які мають
and for
відчувати
people who needs to
підтримку.
feel
Ну і тепер, власне,
support
до початку
coming to
нашої
them. And
спільної
before
розмови
we start our joint
розпочнемо
line
з
of work, we can
вітальних
start
виступів.
first the welcoming
Сьогодні з
remarks.
нами люди,
Today
які
with us,
представляють
people
різні
who
рівні
represent
цієї
different
системи,
parts of the
державну
system,
політику,
state
міжнародне
policy, international
міжнародну підтримку,
organization,
фінансування
the
медичних послуг,
funding for
громадські
medical
історії та
services, public
практичне
health, and
впровадження змін у
practical
громадах.
implementation and
І
changes
саме
in the
завдяки
community levels.
такій
And because of such
взаємодії
an
стає можливим
interaction,
рух
it
від
becomes possible
окремих
to move
ініціатив
from
до
separate
системних
initiatives to
рішень.
a system-wide
З
solutions
великим
in decision.
задоволенням
With the
запрошую
great
до
pleasure,
нашого
I would
першого
like to
спікера.
welcome our
Ваші
first
оплески.
speaker under your
Запрошуємо
applause,
Євгенія Гончара,
Yevhen
заступника
Honchar,
міністра
Deputy Minister
охорони
of Health
здоров'я
of
України.
Ukraine.
Доброго дня, шановні колеги.
Good morning, dear colleagues, participants of the conference. I would like to say thank you for an ability to join you in this effort. Today's conference is dedicated to early detection and screening, one of the key areas of work of the modern development in health systems. With joint efforts, we are moving forward from the model of health response to health prevention or early detection and risk management. This is an important part of the state policy in public health, dedicated for the reduction of incidents and the improvement of quality of life for the population. It's important to understand that the screening is the first stage of early detection of the disease. At the same time, screening itself is not the end result, but the result is the timely diagnosis, a timely started treatment and preservation of health for the population. This is one of the priorities for us, is to the continuity of care to be there from screening to diagnostic, detection, and further treatment. And at that stage, we have key system-wide challenges that are connected with the loss of the patient, or the key role in managing those challenges is primary care and community. So at this level of care, we have the access to services, for the trust is being formed to the health system, and the practical results can be reached. This is why I would just like to express my deepest gratitude to communities that are the ones implementing those approach at the local level. Because of your daily line work and involvement and responsibility, those initiatives are becoming live and are gaining results for people. Separately, it's important to say about the integration of approach. Screening has to be looked at a part of the comprehensive system and align with mental health, NCDs, and tuberculosis, which allows us to use resources better and provide better results for the patients. And on the national level, we are also working on the establishment of specific conditions for that. We are setting the priorities, we are developing financial tools, we are reinforcing the monitoring system and the use of data for the decision-making processes. And I am convinced that today's conference will become a platform for the expert experience exchange, key challenges discussion, and working on the practical solutions for all of us. From the Ministry of Health of Ukraine, I would like to say thank you to our partners, which is the TB combating projects, the PATH, and US government for step-by-step improvement in health because of you and because of us. Thank you so much. Thank you so much, Evgeny. Thank you so much for your kind words and such a specific description of the vision on the national level. And right now, we would like to welcome Jeffrey Juka, the Senior Coordinator of Support from the US Embassy to Ukraine. Jeffrey, the floor is yours.
Good morning, everyone. On behalf of the United States government, I'm honored to join you for this important conference on strengthening community health systems in Ukraine. Thank you to the Ministry of Health, the National Health Service of Ukraine, the Ukrainian Center for Public Health, and PATH for organizing this gathering, and to all of you who have traveled from communities across Ukraine to share your experiences and expertise with all of us. The work that you are doing, building integrated systems for early detection of non-communicable diseases, tuberculosis, mental health support, and infection prevention, it is all essential. These are not abstract policy goals. They are about ensuring that people in every community can access the screening and the care that they need close to home. What makes this conference particularly valuable is that it is grounded in practice. Over the next 2 days, we will hear directly from communities about what is working, where the gaps are, and how to move from detection to care. That kind of practical, evidence-based exchange is how real progress happens. This conference comes at an important time. The United States and Ukraine have long-standing cooperation, including in the health sector. Our vision for multi-year joint effort encompasses health system strengthening, infectious disease control, and using data for decision-making, all of which are priorities for both countries. Supporting Ukraine's tuberculosis and community health screening program is a practical investment in U.S. security and economic interests. By strengthening data-driven, community-based health systems, the United States reduces biosecurity risks, opens opportunities for American companies, and advances the priorities of the America First Global Health Strategy. The United States supports Ukraine's efforts to strengthen community-level health systems, and this work reflects a shared commitment that quality health care should reach every person in every community, regardless of where they live. This approach underscores how targeted health assistance can advance U.S. interests while delivering tangible humanitarian results. We look forward to the discussions ahead and to learning from the innovative approaches that you are implementing on the ground. Thank you all, and let's make these 2 days count.
Thank you so much. Thank you so much for the partnership and, of course, for the steadfast support of our country. Thank you. Ну що ж, пані та панове, а зараз до вітального слова запрошується Наталія Гусак, голова Національної
And with
служби.
that, dear ladies and gentlemen, we're happy to invite Natalia Husak, the chair of the National Health Service of Ukraine, with her opening and welcoming remarks.
Не готувалася до вітального слова, але
As a matter of fact, I was not preparing any bullet points for this opening address, but following up on the trend you are setting, dear Timur, let me carry on to emphasize how valuable and precious these moments are and will be today when we are discussing prevention, communicable, non-communicable disease. I do remember the long time ago, before the war started, I took part in a public health forum in the Olympijski Conference Center. And there we also were partnering with the United States government and their organizations they are supported, discussing the importance of communities. And I do remember some presentations by local community representatives from Chernivtsi Oblast about iodine deficiency among children. And now, 10 years after, working on the daily basis, we are not only witnessing, we are the actors who made this possible. We can see how community role is being strengthened, and also we can see a clear focus on the actions that we have to take into the future for the benefit of our people, of people who live in the small communities, of people who serve as family clinicians, for the benefit of other people, including those, it doesn't sound nice from the point of view of health financing, but we have to be talking about some savings in the health sector, not at the cost of health, but for the benefit of cost-effective quality of service to be delivered. And thus, we have to be discussing the paradigm of actions, and I am happy to express my and our appreciations to the representatives of the United States government for sharing your support with such projects in Ukraine, because these are the projects about the people. These are the projects for the people. These are the projects focusing on the people's needs. Because if somebody believes that at the time of war you should be neglecting help, then they will be terribly wrong. Even at such harsh times, we have to find strength, resources, and passion to support Ukrainian people in this country. Thank you for doing that, and thank you for being with us.
Дякуємо, пані Наталю.
Thank you so much, dear Madam Natalia. And I do believe this was absolutely appropriate and relevant. And with that, I'm happy to invite Vitaly Koblush, Deputy Director General of the Public Health Center under the Ukrainian Ministry of Health.
Шановні колеги, шановні
Dear colleagues, dear participants of our esteemed event, dear community representatives, and also representatives of the healthcare professionals, speaking on behalf of the Public Health Center, the National PHC, I'm happy to welcome all of the delegates who joined us offline and online. I do hope and believe that these 2 days will be definitely fruitful. We have a wonderful platform for discussions, for better understanding what screening is, not only as the process, but also as an element in the healthcare system. We all agree that early detection of different diseases, including tuberculosis, is one of the strategic elements in building the modern healthcare system in Ukraine. And timely screening, case finding, and full diagnostics, as Madam Natalia absolutely correctly suggested, will be helping not to save some money, but to optimize some use of money that we have in the system on the one hand, while also serving for the best patient's interest, which will result in reduction of mortality, and also will provide for better health, longer life expectancy, and better values for the entire nation. Also, we have to understand that the importance here is with the role that local communities will be playing in that process, including organization, logistics, support for the benefit of the screening efforts in different levels, not only focusing on the process of screening itself, but establishing this relationship between local communities, the Ministry of Health, CDCs, PHC centers in their respective locations, which will be serving for the best patient interest and also guiding such patient along the pathway. And this will be designing the model of success, a functional model of successful healthcare in its essence. Also, I'd like to emphasize that this joint intervention, which is implemented with the support of PATH in the context of implementing the project that is supported by the United States government, and also to thank representatives of those communities who serve their duty in their respective locations, working on the daily basis, making sure that these processes get on rolling. I also would like to thank all of the participants who are joining us online, and also the armed forces of Ukraine. This was absolutely appropriate, Timur, to mention that, because they make this possible to happen, including this event. And on that note, happy to wish all of you and all of us productive 2 days of work, which will generate lots of ideas, which can be translated into helpful practices, and also wishing peaceful sky and no missile strike alerts, at least today. Thank you so much, dear Mikhailo. Thank you to the National Public Health Center for emphasizing the importance on building this broad framework of screening, prevention, and making sure this is going into the further pathway. And with that, welcoming Gunta Dravnitsa, the team lead of the project for supporting TB control efforts in Ukraine. And my warmest welcome to all of you, dear colleagues, dear friends, and community representatives, for all of those who care. Thank you for being here. And indeed, special words of appreciation go to local communities and their leaders, because we have to appreciate that everything starts at the local level, where the people live, where people act on a daily basis. When preparing this event, we were visualizing the system as a tree, with the roots, with the trunk, with the trees and leaves representing different elements of such system. remembering that people are behind each of those elements. We also are thankful to the US government and the State Department of the United States for establishing this supportive environment which builds up this platform. And this platform definitely will become the place for sharing between national institutions, regional partners, local communities, and other stakeholders, so that indeed, bringing our thoughts together, we can find the best possible approaches to advanced screening, diagnostic, and follow-up care. But let me take it beyond that. We want to make sure that this platform is the open space for constructive decision making and decision implementation. And once we start sharing such experience, we will be scaling it up on the next level. And I hope these 2 days will be full of friendly, contentful, and helpful discussions for the benefit of best practice sharing. Thank you once again for your commitment, and please be invited to start. Thank you so much. Thank you, dear Gunter, also for your inspiring address and also for your leadership in initiating these challenges. With that, dear ladies and gentlemen, please be invited to another round of applause to thank all of the speakers that came to the stage at this moment, but also be prepared for more. We will be making this event as interactive as possible, and let us give it a try to see how it works. Please take your smartphones, open your QR scanners or cameras, and scan the QR code you can see here in the screen. And once you are referred to our survey platform, do answer the questions that you can see on your screen. Our first question would be, should every patient go for diagnostics after the screening? And either yes or no would be the applicable versions of the question. And again, such surveys will be used throughout our work tomorrow as well as today, regardless of you joining us offline or maybe online, whether you're in your working station in the front of the screen or using your camera and smartphone. So please make sure that your voice counts. We will have a pool of questions today, another pool of questions tomorrow, and we will have prizes following that. So please be prepared to engage actively. I can see that some of you have obviously responded. Please take your time. We have another 15 to 20 seconds to answer this question to make sure you are fully convenient with using this online survey. This opening question is quite fundamental and simple, but that will help us better understand what should be happening with a human being following a screening event and how to take it further. Have all of you managed? I can see most of the people are nodding. Okay, let us allow another 10 seconds to finish. And our final countdown, 5, 4, 3, 2, 1. And now we stop, at least at this moment in time at this stage. Once in a while, again, to make sure this is as interactive as possible, we'll be inviting you to such polling questions. And with that, let us get prepared for the next block of our conference. We have already outlined the framework for our event, and now let's see into the elements of screening, because we'll be discussing the policy, the people, their preparedness to make their action, both individuals as well as communities, which are designing and making the system functional, starting with the national level, with a policy setting, which will establish the environment for the policy implementation later. And with that, I'm happy to invite Yevgeny Gonchar once again, reminding that Yevgeny Gonchar is the Deputy Minister of Ukraine, with his presentation about the National Screening Initiative, describing the context and priorities. Good morning, once again, warmest greetings once again. Let me invite your attention to my presentation about this initiative, which is implemented this year, describing the 40+ health screening initiative.
Програма Screening 40+, це
The Screening 40+ initiative is aimed at providing screening services to people at the age category 40 and older to identify cardiovascular risk, diabetes mellitus second type, mental health
ті захворювання,
concerns, which are
більший тягар
primary
захворюваності в Україні.
burdens of disease. If you look at the incidence structure in Ukraine, and not only incidence but mortality as well. But most importantly, these are preventable diseases which can be identified at the earliest stage possible and thus prevented or treated effectively. And we have to admit that despite having effective treatment options for such diseases, and also having effective diagnostic methods, having all of the guidelines and protocols and treatment approaches to help such patients with cardiovascular diseases, for example, but at the same time,
Стукатися до пацієнтів,
the most challenging element in making that service available is making sure that the patient is prepared to use and benefit from such service availability. And this is the challenge that Ukraine is facing, as well as many others in the world are facing. Not just more. It would be appropriate to say that majority of the countries in this planet are facing the same challenge: how to make this service available and useful for the patient. Speaking of the Ukrainian initiative, from the point of view of a patient, that would be timely identification of the disease at the earliest stage possible, early admission to care, and effective treatment, making sure that health and life of the patient is protected, and at the same time, maximizing the efficient use of funds within the system and thus revolving it into the salaries, to better logistics, to better equipment, and other motivators for the system and healthcare professionals, which again will be serving for the best interest of the patient, healthcare facility, and the system. The initiative was launched on January the 1st this year, and invitations to come for screening will be coming to the DIA application of respective patients within 30 days from the date of their birthday. And thus they have the window of opportunity and they can present to any healthcare facility, including public, private, municipal healthcare facilities, and understanding that the public healthcare is the most diverse in the terms of its representation, then definitely they will be the ones who are most actively involved, taking the lion's share of such intervention. And as I can see, the number of delegates coming from such facilities in this conference would be the greatest. And the number of such facilities will be growing on the weekly basis.
що входить в програму
Describing what is included into the Screening Health 40+. First of all, there are 3 categories of patients who can be referred to different categories, and there is respective eligibility criteria and services. The first category will be conditionally healthy patients. They will be scored on the fund-raised and physical examination and laboratory screening panel and mental health screening as part of that package. The same will be offered to the patients who do have some history of cardiovascular diseases, maybe hypertension or some other indications, and the same relates to diabetes mellitus. There are additional elements of the service included into such package. This is well detailed in the specification supporting the project, and I believe that all of those who are implementing this intervention are well familiar with that. But importantly enough, that all of the services included into such package are evidence-based and realistic, and they are available at any healthcare facilities that you will be referring to. Another important element being the service this because there are some requirements applicable to the integrity and the quality of such services that will be offering better engagement of the patient, being patient friendly, and uh, making sure this is also convenient for them, and thus making the service available at different times of the day, including early hours, late hours during the working days, and also weekends, making sure that even those patients who have busy working schedule will have an opportunity to seek doctor's advice during the days off, which is a small but important element making this service more comfortable, more convenient, and better accessible to the patient. And this is a standing routine for private facilities in the public sector. This is quite an innovation, and that's exactly where additional resources will be going to. Speaking of the initiative budget, which is making sure that the facilities are open at the patient's convenience time. Looking at some numbers, over 540 million Ukrainian hryvnias have been already dispensed for the benefit of patients who requested the service. But the number of patients who enjoyed having this service is quite small, 25,000, which is growing on the daily basis, but yet there is a lot of area for improvement, in my opinion. And definitely we'll be using this available space for improving communication with the primary care centers and the patients, and also mobilizing the preparedness of the patients who have signed declarations with their family care providers, engaging local communities for broader publicity of these initiatives, making sure that this offer generates demand. And the supply of the service is matched by the demand that will be growing respectively, as well as incentivizing their providers using some financial tools as well, making sure that we can use it effectively on top of the capitation rate which is available. Also, addition to screening, there is a comprehensive service package for patients with cardiovascular diseases. And this year, we also are improving the financial mechanism for planned cardiosurgery, stenting, and we also improving the capitation rates here. And our objective is to make sure that cardiosurgical services are more accessible to the patients. On top of that, we are improving the reimbursement program under the Affordable Medicines Program. And this week, some of the patients will already have access to those medicines which have not been included into the reimbursement schemes, the anticoagulants for peroral intake and some other drugs as well.
What we've heard is the biggest request from the patient, been starting from July of this year. We are planning to have the biggest in history widening of the reimbursement program, specifically for the cardiovascular condition medication. So we want for patients to be able to get all of the needed medication for the outpatient treatment that they might need. Also, we are planning to change a set of approaches for how funds are transferred in the screening program. Hopefully in a week or two, it will be enforced. It's not going to be connected to the birthday of the patient. So the patient who's 40 and older, independently when his birthday is, to ask for funds and to use the funds for screening. Plus, this can help health facilities to be more organized in doing that, to go into factories or companies or to rural areas, and then to create groups of people so that you can make these services more widely spread, more system-wide. And we are hoping that this would increase in the selection of patients and will make it much more easy to use. We're also planning for funds that are being allocated in the funds on the patient's account. They will be there for only 2 months, and if in 2 months he didn't use those funds, then they will be getting back to the state budget. In our opinion, this needs to stimulate the patients to reach out to health facility, because right now we are seeing many patients when the ones that are requested for funds, and why are you not reaching out? They're saying, but I still have a bit of time till the end of the year. And then closer to the end of the year, as we understand, patients are forgetting about this. It's not needed anymore, or if they all come at the same time, this is going to be a bigger load for the health system. This is why we're planning to have those changes in the nearest time. Thank you so much for your attention. And please show by your own example, go and get your 40 plus screening, since knowing that most of you are 40 and over. Thank you so much.
Дякую, пане Євгенію.
Thank you so much, Yevhen,
За чітке бачення на рівні
for such a
політики.
specific vision on the level of policy. And then
Місяць тому мені прийшов
for a month ago, I had an invitation for screening. I haven't used it, so now in the break, I'll register and get my 40 plus screening.
Так, ну що, зараз будемо говорити про те,
Right now, we can be saying without what
програма скринінгу
non-screening program can be really effective, which is about the decision of a person to reach out to for the services. Even the best and most described educated system, probably a person cannot know or not trust the process, or is the main reason they're just delaying reaching out for services. What influences this decision? What kind of barriers exist, and how can we help people to make this step? We will be discussing with you later on. So we are welcome to the floor, Olena Zaporozhska, head of the Department of Prevention of NCDs of Public Health Center of Ministry of Health of Ukraine. And the topic of presentation is medical knowledge and the barriers, medical literature and the barriers from screening and prevention. Thank you so much. Greetings, dear colleagues. It's such a great honor to see all of you here today. So we all know each other and have seen during the trainings for your communities. And I am grateful and I'm happy that we are all involved in the same system into the prevention, screening, and medical services provision for the participants of your community. By continuing the question on the importance of screening, and screening is a critically important part, and as it was mentioned before, it's critically important strategy for public health that has been developed so that we can detect diseases before they reach the irreversible or symptomatic stage in all the countries throughout the world. Proven efficiency, the importance of screening. The first things first, this is the effectiveness of early detection and early beginning of treatment are giving the ability to save funds and are giving the ability to treat the condition or disease in the earlier stages. By the data of the US Association Oncological Association, the early detection of cancer, of breast cancers or initial stages, allows you to for a 90 to 95% full recovery patient, which is really important. And apart from that, screening is important also because it gives an ability to decrease the mortality and incidence as well for the population. And this is in all countries. And also screening gives you an opportunity and ability to start preventative actions before or earlier. And some types of cancer screening, for example, colorectal cancer, it gives you an ability to, these types of screening gives you an ability in the initial stages to conduct the intervention and not allow for cancer to develop and spread. And also from the countries where the screening is giving the ability for the intervention for health of the population and health of every individual, and provide the data for the monitoring for health of the population and also for the whole country. At the same time, as it was mentioned by the representatives of the Ministry of Health and National Health Service of Ukraine, this is the economic opportunity to optimize expenditures for health. And so we can't waste this wonderful opportunity. At the beginning, we understand that the screening requires additional economic inputs, not significant, but still And then this economic efficiency is proven before, even for small investments in the screening stage, they're still giving a enormous income. So saving funds for treatment that otherwise would go there. So that, but if we're speaking about screening, we need to say that the screening gives us the opportunity to prevent diseases. We all know about the primary prevention, with the ability to stop the disease before it appears, and we all know about the secondary prevention. This is timely detection and timely intervention in health of the population, and the tertiary prevention that gives us an ability to hold and control conditions that the patients have. This is control of arterial blood pressure, control of the blood sugar levels, and cardiogenic rehabilitation. But the main thing that we all need to remember is that any kind of prevention starts not from the recommendations that were given by the doctor to the patient. It starts from the patient was able to understand those recommendations that were given to him or her by a medical expert. And then I'll move to medical literacy, because without medical literacy, a patient, no order or anything that was made in the country, no kind of assistance or screening points that is in the community, that's not going to give the effectiveness if the patient themselves, the person themselves that are living with you, they don't understand the recommendations for medical personnel. And so right now it's very popular, the position or approach of the improvement of medical health literature from the patients, the health literature or literacy. By the WHO definition, medical literacy, this is the personal knowledge and competencies that have to be in the individual or in the community so that they would know how to make decisions on the state of health, to understand their bodies, to understand their level of health, and to interact with the health system. Health literacy can be personal or individual. So this is the knowledge of every separate person. This is their own level of perception of the information, and also the level of opportunity or ability to make decisions on the state of health. But at the same time, there is also this meaning, this organizational or medical. This is the medical literacy that gives an ability for organizations, to every ambulatory, to every health facility. They're providing this opportunity to use all the activities, all of the efforts to improve their capacity to provide quality, high quality, and understandable services for medical workers to be able to have the skills of talking to the patient, to improve the general medical literacy in the community. The key components of medical literacy, there's a few longitudinal parts of the medical literacy that we all need to know. It has to be useful for each and every one of us, because we are also patients of sorts. We are also parts of communities and are patients of a health facility. There are scientifically grounded the medical literacy competency cascade, or NB as the public health center, and U as Centers for Disease Control and Prevention, and the representatives of primary care. We have to develop it in patients so that they can improve their literacy. The patient has to acquire such competencies so that they can find the information, to find the up-to-date evidence-based information about health and about and methods for treatment, so that that patient will be able to find information and trust that information, and to understand it as well. So the understanding of medical information, this is also one of the points of medical literacy for patients and for doctors to be speaking in the same language. So the patient also needs to know how to interpret the recommendations of doctors that they're providing, because this is important and this influences the future results for treatment and prevention of risk factors for every patient. Apart from that, the person has to have a critical thinking approach to any information provided and to know how to assess this and to understand like how truthful this is regarding their bodies, regarding their diagnosis, and regarding their state of health. Apart from that, every patient, every person need to know how to use the information and to move this information and the practical actions and skills. Apart from that, a modern world that health system in which is providing digital methods, apps, applications for use of the electronic medical system, and the digital literacy of patients is also a component of the health literacy. And in any case, for us and for all of you, we need to improve it and increase it and to explain to the patient how to use this, because digital literacy is also one of the small steps for the understanding by the patient of the general setup of the system and the structure of the system and how is it functioning. And apart from that, one of the main and important factors for health literacy is also communication. So an ability to interact with the health workers and then to put the correct questions for health or to describe the symptoms correctly. This is also an important part, because not a doctor on the primary care can in 1 minute without explanations or the doctor can't really read your mind and put a diagnosis. They can't really put your attention to maybe some of the factors that the patients have. As you probably know, the conduct of the physical examination lab test, this is an important step, of course, but for a doctor to prescribe something, the patient has to describe their symptoms, the way they're feeling, and then so that patient and doctor would understand each other. And also, if let's imagine a utopia, but we have to reach to when all the patients will have a high level of health literacy, what kind of advantages the society will get. Those advantages will be received by the patient in their individual level, and those are the advantages when the patient would be able to have the ability to make their own decisions on their health, on their well-being. They will be able to and will be following all of the recommendations from the doctor. They will be perceiving well the prescriptions that doctors are making, and then they will also be encouraging for an active, will be themselves involved to the active participation. And then on the level of organization, they're going to be, the advantage is going to be that there's going to be an equal access to medical care for all the participants, all the parts of the community, and it's going to reduce the barriers between the patient and medical system. And for all the groups of population, the barrier is going to be decreased likewise. And also on the level of the organization, to improve the medical literacy and health literacy will improve the communication between the services providers. And on the level of the policy as well, there's going to be a great advantage. On the level of state policy, we do understand that this is the reduction. It means the reduction of the burden for a health system overall for the country. But you need to think about the communities that you live in. If the population of your community is having high level of health literacy. This will reduce the financial burden for your local health systems and the economic burden in your community. So we are speaking about economics, and this is on the level of the person, level of the community and the country. There's going to be reduction in economic burden, but we also need to think about the state of health of every person separately and all the parts of your communities, meaning to improve a small factor to improve in-house literacy or of every neighbor that you have, parts of your family or your community. It will lead to the improvement, general improvement of health for a longer and productive and active life. For example, I would just like to demonstrate to you the results of our research that we have conducted in 2 regions of Ukraine, those with pilot research in Lviv and Khmelnytsky region by the Center for Disease Control and Prevention and health facilities that have been involved for the conduct of those research. It was the assess of health literacy of the population on the blood pressure control in different communities and different regions of the country. And it's there have been different levels of medical literacy. I'm not gonna really go in depth, but when in the community or in every patient, they had a high level of health literacy, they had increased trust to the doctor and to the health system, and they start to make the decisions themselves on their health status, the low level of health literacy. And this was found out by us during this interviews with patients as medical workers. And so this low level of health literacy is actually showing that the patient has a low level of trust to the health system, the low level of access to health information, and the person doesn't know, they don't know how to navigate the system. So for example, they don't understand why the prescription was made, they're not filling them out, and they're not controlling their state of health, so they're not controlling blood pressure, not taking medication for anything, and which leads to the decrease in the level of health and secondary complications as well. The profound interviews are saying that people perceiving differently both the prescriptions made by the doctor and don't understand their diagnosis, and this leads to in the future for the decrease in level of health and absence of control for hypertension. You can think of other conditions and diseases what the absence of control might lead to, and this does not give us the any kind of progress in treatment, and this vicious circle closes up, and then the economic burden increases both for the family and to the community and overall health system as well.
Throughout the entire world, in order to improve such health literacy, there are some approaches, there are some steps to be taken, and some tools to be used. First of all, communication with the patient, by means of which the patients receive clear to understand indications and instructions, some materials that will be helpful for them. Because as we know, sometimes a healthcare provider does not have enough minutes per patient visit in order to provide the full description within that counseling session, and thus compensating that via handout materials so that the patients can read at their leisure time back at home and thus better understand what is this prescription for. We're working on that, making sure that such handout materials would be quite diverse and helpful, and we hope that PATH will be providing additional assistance here as well. We will be happy to share the designs, the templates of such handout materials to be printed, making sure that we have enough copies for distribution to the patients for better health literacy of the patients. To improve that even further, we also have to improve access of patients to self-control options. Speaking of arterial hypertension, for example, as you remember, pharmacies, libraries, screening points, they have equipment available, and this is very helpful to build a network of hypertension monitoring network. This is quite basic. Just take a pressure meter, invite a patient to spend a couple of times, a couple per week, a couple of minutes per session to make sure this is monitored. And also this will be helpful by some organizational changes in health facilities and non-health institutions as well, where a local nurse will be invited to such monitoring sessions, provide some basic information for the patients, remind them about the importance of monitoring their blood pressure, provide some other recommendations, make a reference to a clinician if and when necessary. In other words, making such small steps which cost a penny, but with the return on that investment being huge. This will be improved health literacy, this will be improved motivation of the patients to monitor their blood pressure, and also reinforcing that with peer-to-peer support, community-led initiatives, which again will be contributing to the same. Further speaking of such health literacy, which is one of the elements on the one hand and barriers on the other hand, in the context of disease screening and prevention. As the result of our research, which was conducted also with support of the project for assessing the capacity of primary healthcare providers to offer the broad package of services, has demonstrated that individuals living in communities, as well as communities, they are facing both individual barriers, social, economic, cultural, as well as group barriers. Let me describe social and economic barriers first, including financial and logistical. Let's imagine there is an individual who has some health literacy, but such individual are facing the transportation challenge because they have to travel 10 or 20 kilometers to seek help. That makes such service not accessible. Another financial barrier would be the whole busy working day and working schedule throughout the week, which makes it impossible to visit a doctor unless the local clinic is open during weekends. That's where the 40+ screening initiative is opening this opportunity, while opening the doors of such clinics at the late hours during the weekdays and during the weekends. Another culturally significant barrier would be the fact that there is no sustained practice in families in local communities to ask for help, professional help, before the symptoms arise. Also, we looked at other criteria prevalent in many countries, such as difficulties which the health providers are facing due to time restrictions. Again, they have 15 minutes per patient visit. In many cases, this time is not enough to survey the patient fully, to learn their patient history, to provide the respective advice, to initiate some behavior change. This deprives the clinician of time for some extra discussion with the patient. And also there are some systemic barriers. When, hypothetically speaking, a clinician requests a laboratory test, but local laboratory does not have the respective reagents or supplies, which means that the test will be delayed, and that delays the diagnostic session. And let's not forget about individual barriers. When the patients have lack of confidence in the system, they do neglect their health. There are some gender-relevant barriers, which is quite prominent in Ukraine, whereby the male patients are members of the hard-to-reach category when it comes to their health. Number of years ago, we started a survey in Ukraine, which turned out that about 60% male patients, despite arterial hypertension, despite having prescription from the clinician, they do neglect the importance of monitoring their blood pressure and taking the medication as they should. So my appeal to the male patients is please do care for your health. Please abide by the prescriptions made by your doctor. Further on, in order to improve the prevention, the screening, and control of diabetes mellitus, here we also conducted in-depth interviews. We surveyed the clinicians and other health professionals as well as patients about their personal and professional experience here. I won't be listing all of the facts and numbers. You can see that displayed in the slide, but let me emphasize that the major challenges for the patients, despite having support from the clinicians, despite having the medicines, despite having the affordable medicines program covering that, the most challenging, the major barrier for the patient would be to change their lifestyle. As an example, diabetes patients have major difficulties in making a behavior change in the context of nutrition and diet. This is fundamental. This is easy. This does not require any financial investments, just changing your lifestyle, and that is the major challenge for the patient. Let me leave these two QR codes with you. Please make a copy of that. So here you can access the results of our studies, both the pilot and the core survey about guarding hypertension and the capacity of the PHCs to provide service packages to people with diabetes mellitus when it comes to sugar intake. So please feel free to save these QR codes. They will forward you to the collection of our survey results that will be helpful for your decision-making and for decision-making of your communities and community members. Thank you so much, dear Elena. Thank you for describing the surveys and research you did. Thank you for sharing the results, which definitely will be helpful for us to better understand and strengthen the system. Following up on that logic, let us look at the approaches and the implementation where communities become the agents and actors of taking that changes to life. Not only working within the system, but also working within the community. And I'm happy to invite Yana Terleyeva, head of the TB Management and Control Department from the National Public Health Center under the Ministry of Health of Ukraine, with her presentation about TB-free community initiative. Warmest welcome, dear participants. Happy to welcome and greet you on behalf of the PHC team. And special thanks to having this wonderful opportunity for sharing your platform with me to better and describe what can be done in the TB management context at the community level. I'd like to start with acknowledging the fact that, unfortunately, TB is a global burden and problem. Based on WHO data, annually, just imagine, more than 10 million people have active TB, while remembering that this is a curable disease. Over 1 million of people annually die because of TB-induced conditions and complications. One of the WHO goals, quite an ambitious goal, is to eradicate TB by 2030 as a public health threat, and full eradication by 2035. Speaking of Ukraine, which now is surviving the full-scale war, eradication of TB in country at the national level is an overly ambitious But this is where and why the TB-free community initiative comes in hand. Because by means of establishing such centers, clusters, and networks free of TB, we'll be taking us step by step closer to accomplishment of this ambitious goal, which is TB elimination and then eradication, catching up on some of the pitfalls and difficulties we observed earlier. So now, let us see the situation as it has been established in the country, because TB is one of the urgent challenges we are facing. And despite other challenges, we do see that we are managing to keep the situation with TB under control, while at the same time, there are some risks of that situation to be aggravating, and such risks are quite high. And unfortunately, these circumstances will persist even years and decades after the war, as the history has demonstrated, looking at the lessons we learned from other post-war countries. And again, looking at some of the statistics, we can see some reductions and decline in TB prevalence. Looking at the Q1 data of 2026, we can see 16% decline as compared to the previous year. But we do understand this quite clearly, that in the context of the war, there are other challenges, there are other processes, including migration, is more diverse than just internally displaced people. There are other migration processes going on, sometimes under the surface and remaining hidden. So we have to remain in clear focus of our attention in order to monitor that closely and keep under control, manage appropriately via having the clear and cross-cutting national policy, starting from the national level and down to the level of communities. And looking into the capacity that we have all of the prerequisites to have that, starting with the health legislation, which is fundamental, and also the TB-specific legislation, which provides for a clear role and capacity of local self-governance institutions and systems to be engaged purposefully, and thus enabling them to design local programs which will be customized to those nuances, problems, and specific features of individual communities. There are also fundamental provisions to support the HR capacity, remembering about the HR shortages, migration before and during the war, but also broad tools, and not just number of tools, but rather toolkit, which enables us to address and resolve all of those objectives and challenges regarding the people's lives, people's dreams, people's future, both the individuals as well as the communities and the entire nation. Understanding all these challenges, the team of PHC, working with the support from the Ministry of Health, has initiated this project, which became part of the strategy for 2024-2026. And one of the important elements of the strategy would be implementation of the strategy for TB-free communities in a nationwide dimension. Such concept was approved by the Cabinet of Ministers of Ukraine, so we have the highest possible level of political commitment and support. Looking at the goals that we set back in 2024, whereby we expected that 15 communities will join this initiative, and then 70 in 2025 and 100 in 2026. We will look at the accomplishment of those goals, but remember, in 2024, we had zero local communities were prepared to engage, which again emphasizes how difficult this initiative is to be actively implemented. But once there is a clear leadership, the progress will come over. And looking into the role of communities in that initiatives, it can be described in such a paradigms. First of all, providing for accessibility of health services, because here at the community level, there are PHC providers, specialist facilities. Sometimes there is some fragmentation and gaps between their coverage. Sometimes they are not fully capable of providing the continuum of care, full scope and quality of care, and their capacity has to be improved and developed for the better accessibility of services, particularly when it comes to outpatient care, because people may lose their jobs, people may lose their residential property, remembering about the threats of war, and that might be depriving people of the prerequisites to successful recovery from TB. Another important block would be the social support, social protection, making sure that social and medical components are brought together, which is another challenge as of today. And also implementing the family-oriented approaches, because unfortunately, even today, if there is a person with TB living in a family, that becomes the problem of the entire family and not just the patient. Financial burden being part of that, because we do observe, based on the community reports, that sometimes such families are experiencing catastrophic expenditures, which means over 20% of cumulative family income is used for the benefit of TB treatment and care of the person with TB, who is a member of that family, remembering that TB treatment is free of charge in Ukraine, including medicines, modern regimens, and other therapeutic approaches. And let's not forget about S&D, stigma, discrimination, remembering that today we live in the age of artificial intelligence. We have networks, we have technologies, we have internet on our side. Despite all of that, people do not know what TB is. They do not know that TB is curable. They are ignorant about the symptoms, and that prevents them from effectively seeking care and benefiting from that care. And speaking of the initiative, it has to be based on the principles that patients have to be provided to high quality, free of charge, accessible, and effective care support, not only during the diagnostic and treatment, but also as part of follow-up. And also the communities have to be looking at the financial efficacy and providing for multi-sectoral approach to overcoming the TB and supporting the patients with TB or those who recovered from TB, remembering that percentage between the medical, social, political, and humanitarian should be well balanced. And thus, this is important to understand that at the level of communities, we know who the local people and actors are, and we know how to bring them together to overcome all of those barriers. Of course, based on the effective policies that are available at the national level. But as I mentioned earlier, we have the laws, we have the policies, we have the strategies, but they have to be implemented locally, in local communities where people with TB live. And that has to be sustained for the benefit of healthy environment where every individual has access to the modern evidence-based information and practices, and also accessible support and care options, not only at the stage of treatment, but also even earlier, preventing TB and also preventing the contraction of TB.
Let's have a look at what kind of results are we having, but the great idea have led us to the fact that we are speaking right now more so about success story. 187 communities have expressed their readiness and signed the initiative of a community free from TB. This is a great line of work from the state institutions of the regional administration, Center for Disease Control and Prevention, regional TB centers, partners, heads of communities, and the whole list of participants who have been involved in making this. It's a great pleasure for us that we are at that level of the responsibility and knowing what the issue is, that the leadership started to be caused and the near the frontline community started to be Donetsk. 19 communities that have joined this initiative. So Luhansk region, 11 communities, all of them have joined to this initiative. There are leaders among more of the safer regions. Rivne community, if you can see Roman, who is standing as well by the great success. 64 communities have signed this agreement together as partners. A big role and a big progress in Khmelnytsky region, in Lviv region, and together with that, there are communities where we are seeing that more conditions to take the responsibility upon themselves, but at this time they have not yet disclosed their willingness to participate. Hopefully, this event will be urging and to scale up those initiatives as a part of the separate initiatives for communities free from TB, or as a part of big comprehensive programs on health of communities. Right now, the health is one of the most valuable investments in the future of our country. So here we can see only a small portion of our regional success stories, and those pictures show the results, but there's a lot of people who put their time, effort, and work that has been joined by one singular objective to have the communities free from TB. What are expectations? And if you would look at a few of the main issues that our national TB program is facing, and the first thing is that you have to point your attention that in the country, even before the invasion, there has been a big issue of under-detection of TB by different assessments. We know that a big portion of people are not being detected, especially now when it's hard to dream about tomorrow or think about the future, and people need to take care of their own health, the wellness, future. And sometimes this is the really hard objective. If the rural populations that are, with all the assessments that have been conducted, only through the place of residence, they have a restricted access to medical care, separate communities, minorities, internally displaced people that live in the in the spaces for the IDPs, where there is a group living situation, and a lot of them cannot reach to the health system. In such a situation, the system can come to a person. So one of this instrument is the mobile ambulatory or mobile health unit, and with the support of the public health center, with the support of the Global Fund, with the support of the partners, PATH and other organizations, Medicine Sans Frontiers, Red Cross, Alliance for Public Health, Project Hope, and other partners that are implementing such an initiative. But it was the great thing that they are depending on donor funding. And here, there might be a role for communities when the communities, by knowing that there is an issue of TB, they might initiate their own programs where they would add the owners of those mobile units and to make a screening of their population, not just for TB, because in our observations so far and conclusions, the most effective ones are the screenings. So they're being conducted not just on TB, but also are doing the integrated oncological, reproductive health, mental health, and others as well. So this comprehensive approach is the backbone of success, of clinical success, economic success of such screenings. But together with that, when such funds are being spent and so much efforts in the local levels, we are facing challenges such as that a lot of efforts have been put. 100,000 hryvnias cost of detection of one person with TB using this mobile screening methods. And then this person is not reaching out to treatment because there's no connection and no pathway between the medical system. And so the person was lost in the community and doesn't know where the person is. This is why we need to make it that way, so that there any efforts that is being put, they would have their results coming in. And also, this is not always the safest line of work, so we are grateful to the ones who are conducting it because the activities for mobile ambulatories, mobile communities are accompanied by the drone attacks, mines and explosives. But every time you're calling, and no matter what kind of shelling, no matter what kind of situation is, the people who are going and attending those screenings, it's important for people, and we need to think how to provide for this accessibility for them. We also remember today when medication is there, prevention is there, knowledge is there, modern approaches is there, but one of the biggest barriers is stigma. And you would think that's such a simple thing, but so that to change the approach of people to TB, we were working for a few hundred steps and tens of years. What do we need to do to fight stigma? And to think that first we need to think about the problem and then to have a comprehensive approach, an integrated approach with such a involvement in the conduct of the big system line of work. We know the general numbers for 2 times we have conducted the research by our partners, 100% Life, in the partnership with other agencies and organizations, the assessment of level of stigma. It says that at least every third person that have faced with TB have faced also with stigma. And frequently because of that, people, when they're reaching out for medical care, or like being leaving health system, this is why we need the info campaigns. And now in April, we are making the conclusions of a big information campaign that was conducted in all of the country throughout the March by fighting combating TB. We see wonderful result. More than 8,000 info campaigns have been conducted. It's a big line of work, and then in national institutions and the partners, communities, and medical institution center for disease control and prevention. And so we are also seeing that at least 602 activities has been conducted on the level of communities in the educational facilities, and there's many different events have been happening. And in previous assessments, we were able in a month to cover at least 4.5 million people. But the main thing is for this activity to be conducted as planned, and also so that the for campaigns would be conducted not only in the framework of the months of fighting the TB or combating TB, but also be conducted throughout the years up until the time when we'll be able to fully conquer the stigma and the myths that are covering this disease. We are seeing that great examples with our future, and then probably kindergartens and communities. And also one of the bright examples that we're still having with us, which is this Vyagil community, at which territory we have a great Ukrainian, Lesya Ukrainka was born, a Ukrainian writer and a poet. And so I didn't know that you were the place of person. So this such an activity has merged all that because Lesya was born there, that was fighting TB. Unfortunately, she was not able to get better, but if she would be living today here with us, we would be able to give her the ability to recover from TB. And for many poems and articles from her, she would be bringing even more to her culture. So those kinds of events has to be conducted. We need to have leaders on the local levels that are also can group all of those different sectors with different issues, problems, and everything else to focus on an issue such as TB. And so the main expectations is that all of our activities will lead to really clear results. This is the improvement of epidemiological situation throughout the country, and maybe even more in the European region, because our people are migrating to all the countries. And then the communities are also probably are not as ready to solve issues of TB as Ukraine is, that is fighting within the full-scale invasion. This is the improvement into the awareness raising campaign and improvement on the community level. So we are hoping that the line of work that we have done already, they will be improving. There's going to be a system for the monitoring to track which communities are more successful, how to assess end results, and then there are platforms for scaling up those initiatives. And so also for them to be a big portion of success stories and fighting TB. And by using this opportunity, I would just like to say thank you for your impact in fighting the TB. Because of you, we are becoming a step closer. And to finish my presentation, I would just like was one of the pictures that was inspired by me and brings me hope. It's an example from one of the communities. House gives you wings. And so for all of us to have wings all the time, and for those of us to hold those wings, for doctors, epidemiologists, leaders that would be responsible for that, for all of us, thank you so much.
Дякуємо надзвичайно, пані Яно.
Thank you so much, Yana.
Дякуємо за ваш виступ.
Thank you so much for your presentation, for the research, and for demonstrating to us how this can work on the level of community. We are moving on, and another important element of the system is financing and support for the primary care system. And so here's where the most of decisions are made that determine whether a patient will actually to move on or progress. I invite Natalia Husak, head of the National Health Service of Ukraine. The topic of this speech is the role of National Health Service to support the screening and the community level and the system-wide approach. Thank you so much, Natalia. The floor is yours.
Пане Тимур, я з вашого дозволу
Timur, if I may, I will continue in the same tempo as you did, because heaven was the inspiration that we had at the very beginning, and me as the head of the National Health Service of Ukraine, I would just like to say and speak about funds, or about the fact that we as the National Procurement Agency and the Ministry of Health, we have reinforced the program for medical guarantees in primary care, which is the 5 billion hryvnias additional in the health program for. Yevhen has been saying that we have a separate program for screening, which is 10 billion hryvnias from the state budget, so that we can prevent main communicable diseases as cardiovascular or diabetes. But at the same time, I'd just like to express our realities. So I think that this is it's honest to say what we are really having for that amount of funding that the government is putting into the system, in the reinforcement of the primary care and the protection of the patient, of not letting deaths from cardiovascular conditions to pile up. So I think that one of the events that I have attended, even our international partners are saying that when we were showing the realities that are in our country, we are not even openly speaking about the issues that we are having in the health system. So I think that such a formula as we have today, this is the place and time to speak openly and honestly what we have in the health system, and how can we jointly act, and so that we can prevent, improve, change the situation that we are having in our hands. I'm not going to be mentioning the general thing about the screening as a medical service, and I think that I'll more so stating about our joint responsibility for people, and the responsibility of not just in the level of responsibility that we are having, or in the decisions that we are making, but in the activities that we are doing together to preserve more of our Ukrainians, especially in such a hard time for Ukraine. If we are to say, overall, my presentation will be shared in 3 main parts. The first part, which is cardiovascular conditions, and diabetes will also go here. In a separate portion, I'll show you the oncological screening programs within the program for medical guarantees, and also one of the slides will be dedicated to TB as other communicable diseases that are also within the primary care, so that to prevent conditions. So this is an interesting slide. It shows us how much together when the person is being met by the health system with a stroke. And here it's important to mention that 83% of people who had a stroke throughout the year, they were met by the health system, by treatment. So the 83% of people who got into a hospital with a stroke, they were not visiting their family doctor at least once a year before that. But here, it's what's important is a bit of a different thing, that the story of 83%, we noted this down, but the mortality is what's important, because when you're seeing like what are those, the visit to the family doctor, this is not just about the story of taking the blood pressure or participation in affordable medicines program to correct the consumer behavior or other things that are preventing the stroke. So what's important here to say is that the people, and when we started to compare the mortality, what we saw is that there's two numbers essentially. There's 83% the mortality among the people that were not visiting their family doctor, and 16% and 16.5% was where they had at least one contact before the stroke with their family doctor, or was the cardiologist or any kind of specialist care. This is about where we're losing the people. This is where we are losing the people in the community level. This is not about the size of financing. This is not about the decisions made in Kyiv. This is something about what is happening in every community. And are you analyzing demographic situation? Are you analyzing the change in the structure of the population among the age groups, or are you analyzing the indicators itself? I would just like to say that those indicators, they're not hidden in the country. So most of those indicators by analytical reports are given by every community throughout 3 years in advance in the web page of National Health Service of Ukraine. In 3 years, we are making detailed analysis of work of every primary care in more than 30 indicators. In 3 years already, this is not a part of our responsibility or part of our priorities. It was not supposed to be, but we do understand our role and of our importance to the system. So we think that there was 2023 when there is a few heads of communities, and they can confirm this, when I personally went throughout the country presenting analytical reports so that the community would learn how to analyze where are we losing people, where are we losing. But the biggest thing, I think, that we can twist this story and speak about not the losses, but where can we preserve the most of the people by not letting them reach disability status. And so I will miss this out, even though this is the also a great example. You're gonna have the presentation with the link itself, but this is just showing that this is not a story of human biology. This is not the history of screening and of treatment and by getting with a stroke to a hospital. This is specifically and only the management of health on the local levels and just the organization of the processes, because we have communities. This is in every screening. We have regions that are having better indicators, and we have regions that have much lower indicators. And this is just one simple example, just to wish and just the focus on the work and attention for the patient at the local levels. If you are to mention about the regional dissection or distribution, then here you can see when we are speaking about the data of the e-health system and the fact that we can analyze and that what we can propose in the analysis and correct in policy, it was important for us, not just the history of what was happening with the patients that have gotten to the treatment with a stroke, and also the secondary prevention. How many people after the treatment was from a stroke has gotten back to their communities, and the health system as a primary care has actually seen this person. And in reality, as you can see, that the highest percentage was in Dnipro regions, 37% of people who gotten back after a stroke into their regular lives.
But again, please pay attention that this is the number of people who came back and visited the clinician at least once after the stroke. Speaking of infarction, the situation is not much better as compared to the stroke-related statistics. Nevertheless, 70% of patients who fell into the system with the diagnosed myocardial infarction, they didn't have any visit with a family clinician or cardiologist within a year before that incident. And looking at the lethality rate, again, 30-day mortality following the event, then 68% of those who have not visited their clinician and 31% respectively patients who did visit a clinician. Just close your eyes for a second and imagine what is the number of people's life, number of Ukrainians whose life could have been saved if we made a little effort in our place of work. Coming back to the infarctions further, please pay attention to the 2%. 2% of patients after infarction came back to their family care provider within a year after the event. I do understand your silence, but on top of that, do remember that we have this data disaggregated per oblast, per Ramada, per PHC unit. And again, looking at the Donetsk Oblast situation, I do understand the numbers behind it, but I cannot understand the situation in Zakarpatska Oblast, remembering that they enjoy one of the best financial support rates. 2 days ago, I presented the overview of salary and other remuneration rates in healthcare sectors to the minister. So yes, we have resources, yes, we have professionals, but we don't have numbers. Speaking of diabetes mellitus, if I remember this correctly, it was recently updated, but again, the Executive Order 504 is like a Bible, because we abide by the book. So this order, this Bible, clearly says that we have some risk groups. We have clear eligibility criteria for people at risk of diabetes mellitus. And there is no controversies within. You cannot be confused within the set of those eligibility criteria, but we analyzed what is happening when comparing these indicators. And again, I believe there are plenty of family care clinicians now sitting here in the hall. And you do remember the depreciation rate, so the less people continue coming, the lower rate you will be accrued in your salary sheet. But if we are providing financial incentives for family clinicians to improve performance when it comes to work with the patients from the most at-risk populations, and again, I don't mean this is exclusively the area of responsibility for family care providers, but there are many other tools and actors to be involved. But the fact is that 31% of patients who fall into the risk category, starting with 2020, have been fully screened against availability of risk factors, which means 2 out of 3 eligible patients were not covered by the screening. And here we can see another slide which demonstrates that this is not a problem on the national scale. This is not the problem of the system, because this is not a tool which is inappropriately used. Because look at the situation in Zaporizhia and Donetsk versus situation in Zhytomyr, in Volyn Oblast, where 15% is demonstrated versus 39 and more in Ternopil. On that note, please pay attention if we have any community representatives from Zhytomyr and Volyn. Quite recently, we analyzed the new reporting format, and Zhytomyr and Volyn Oblast have demonstrated the broadest network of felter obstetric care units, which provides for immediate access of patients to primary care. So here we can see the clear dependence. I do remember our visit to Chernigiv Oblast and our discussion with some of the community leaders about motivation, salary allowances, the fact that sometimes they have up to 14 health professionals supporting a doctor in their position, including the principal and auxiliary staff, but their statistics are declining steadily. With that, flipping the page to cancer screening. By the way, coming back to diabetes mellitus, my dear colleagues, each and every one of you, whether you have medical education or not, you should understand that diabetes is not an overnight event. But we have diabetes growing in Ukraine. We have the growing number of patients with diabetes in Ukraine. But looking at the cancer, this is the situation where every step, where every action is quite well time-bound and measurable. And the sooner the system identifies such case, the greater chances such person have to survive. Definitely, we have access to the advanced statistics of the breast cancer. We are also looking into the cancer of the prostatic gland. Maybe 3 weeks ago, I took part in a conference making a report about cervical cancer, remembering that we do have vaccination, we do have screening, which can help us overcome that medical challenge. But looking at the statistics, we analyze, starting with the primary care providers, through the treatment and care, and over into rehabilitation stage. And we are not analyzing isolated elements, we are analyzing the entire pathway. So let's look at the situation with the prostatic gland cancer. 76.5% of patients are not receiving the respective screening referral. 72%, almost 73%, they are not following the screening referral. They are lost to follow up on that initial stage. And again, that would be out of 1 million, that would be 291,000 only. And that means that this is the number of patients who actually received the referral and followed the referral. And also, there is a very clear geographical connotation to that, suggesting that there are some organizational and management-related processes which are either improving the situation or making it worse. And that means we have to communicate, we have to build the relationship, we have to manage the situation appropriately in every possible location, and also enabling the respective management decision-making and the implementation. Not because NHSU is keeping this data to themselves. Alternatively, we open this information for your awareness, making sure that you can engage your social workers if you have to provide additional support to people with some health status, and also maybe getting in together with your logistic and transportation unit to provide for better transportation convenience for the patients to access this service. But again, looking at the situation in different regions, we can see that providing a referral does not automatically mean that full diagnostic service is available and accessible to the people. In some regions, we understand that sometimes people are lost at the initial referral stage or secondary referral. Breast breast cancer screening, not only mammography, but also understanding that the Bible, the Order 504, clearly provides for the algorithm, eligibility criteria for different people at risk. There's clear description of the actions to be taken with such risk group representatives. And here we can see 60% of people from that group at risk not receiving a mammography test referral. Recently enough, we also analyzed for the minister, based on the minister request, the situation with the mammography, but you will be surprised, and the number of modern mammographers per 100% population in Ukraine is higher than that in any European country. While at the same time, NHSU is paying, we are remunerating this service. Over 78% patients who received a referral to such screening, they failed to come and use the service. Another important factor here, we also have to rely on some practical life scenario. And examples of some communities, I do remember this was a community somewhere in Kyiv Oblast, quite a wealthy, well-to-do community, and we visited it just to learn their practice in verification of data. And we met the local chair of that PHC unit. We visited the community leader in the local municipal council, started discussing the problems they experience, and the chief of that primary care unit asked the local community leader to make sure that there is a dedicated day in the local clinic to be provided for the sake of mammography. This is a wonderful idea. And the chair of the local self-governance authority suggested that they immediately will be calling the chair of the executive council, making sure there is a public bus arranged for taking the patients to that clinic. But the chair of NHSU should not be visiting every location, every local community, suggesting that idea. This can be easily done at the local level, because thus you'll be better caring for your local women. And again, let me skip some other details, but looking at the organizational paradigm in broader perspective, we do appreciate the regional differences. The regions have differences. Even within a region, different communities are different, but this is not a matter of available or non-available national policy, because it's there. This is a matter of local solutions, which translate that policy into better health of local people, thanks to cooperation and communication between the local chairs, local chiefs, local actors, and stakeholders. This is not the matter of patients being willing or unwilling. This is about creating opportunities to design a pathway, to provide a local bus, to strengthen capacity of the local providers, and many other hundreds and thousands of small steps and ideas which can make a big difference. Now, looking into the colorectal cancer, again, you can see the numbers, how high is percentage of those who do not access screening, out of those who were referred to screening, failing to come and enjoy the service, and the respective numbers resulting from that. And again, the Executive Order 504 provides clear eligibility criteria, but most importantly, all of that information on the monthly basis, with all of the dynamics and analytics broken down to regions and communities, is published on our website. We also visualizing it via pie charts in our dashboards, so that you can monitor the situation, you can compare the dynamics, and use that information for making decisions that save lives. And again, look at the leaders here, the city of Kyiv, then Transcarpathian Oblast, Chernivtsi. You can see Chernivtsi would be in the second place, but we do remember that only 12% out of the remaining 35%, they actually used this service. They did visit their family clinician. Yana described the situation with TB in an extensive and detailed manner, but we also enjoy different projects, including those supported by international and humanitarian partners. We have major investments coming from the national system and local actors like CDCs and other actors in the field of TB prevention and response. And on top of that, having the technical support, standards available for the pathways, there's probably no other infectious disease which is challenged by our response capacity in a similarly potent manner. But again, this is the matter of abiding by the book. using the eligibility criteria and using the appropriate guidelines in order to make sure that we make the difference. And again, this is about the fact that cooperation and communication at the local level and cross-sectional level is very important. And again, proactive management manifested by the local community can be translated into prevention. Again, Mykolaiv, 17%, Vinnytsia, 9%. This is not about having the policy. This is about implementing that policy. On that note, I will probably be finishing my presentation. I hope my message is clear enough. And I'm confident the screening is not entirely medical service. It's not about diagnostics. It's not about referrals. This is not just a matter of having lab analysis and test results available. This is about management, communication, and integration of different services from top to bottom, from the cabinet ministers to local communities. And again, we're talking about major values such as health and life of people. But in order to have that value cherished, we have to make small steps: prevention, screening, referral. Even if we improve that by 20% over 1 year, in just one of the diagrams which I presented in my slides, that will be saving health and life of hundreds of thousands of people. And again, my appeal also goes to community leaders. Do not treat primary care providers as something elemental, and do remember that this is the first step. This is the gate opening for the people to access the care. Speaking in fiscal terms, this will be providing for savings. We will be saving health and value of working-age people who will be working for the better sake of the community and the nation. So do help them. Help them with prevention and service, while NHSU will always stand our solid ground as your partner. And when it comes to timely and effective financial resource availability, which can be manifested via our action, we definitely are committed to do our best in this regard. Thank you so much, dear Madam Natalia. Thank you once again for sharing this information and for the clear appeal that you have manifested here, and making sure that this entire model will be functioning. And with that, dear ladies and gentlemen, please be invited to another round of interactive polling. We have the second question for you in our 2-day-long quiz that you will be a member and part of. So please take your smartphones, both sitting here in the hall and also in front of any device which you are using for your online attendance. And again, there will be either yes or no to answer the question whether screening equals diagnostics. So the screening, is it equal to diagnostics? I believe you know the drill, and you don't need so much time to produce your answer to that question. And again, addressing both online and offline participants, do remember this is a quiz with a prize, and all of you deserve that. 15 more seconds to finish.
Телефончики дістали, мабуть, відповідь дали швиденько і вирішили одразу там інстаграмчик перевірити, телеграмчик, да? Не відволікайтеся, скоро буде вже обідня перерва, там можна буде і поспілкуватися.
If you have a lunch break coming, therefore you can check your media, news sources, and so traditional we are making a countdown. 5, 4, 3, 2, 1.
Окей, дякую. Я думаю, дякую всім, хто
Thank you so much for everybody who has answered, and I think that's such a short and simple, but at the same time important question. It's making a good segue into the next part in the next talk. What has to happen after the screening so that the person would not say without the future steps? So now, what it looks like in practice, how those approaches move from policies and design to an actual implementation at the community level. I invite to the floor Halina Dragan, past project and the acting against TB. She will present the approach of the project and implementation model from the idea to concrete steps on the ground. Thank you so much, and Halina, the floor is yours.
Чути мене, да? Добрий
I
день.
hope you can hear me okay. Greetings, dear colleagues.
Знаєте, трошечки хвилююся.
I'm a bit worried because after the presentation of the Ministry of Health, Public Health Center, National Health Service of Ukraine,
Не менш і радію.
and I'm also happy because it's turned out to be that all of our approaches and our views are going in line with the state views and ideas and opinions. Because as you all know, the objective of any kind of international support project, which is to support existing national system and to support the country in the places where
Ну, неможливості, так би мовити,
there's an ability to do something or for the betterment of our people.
Тому будемо потихенечку
Therefore, we will be slowly starting. And I would just like to say that today we will share the experience of our project that we are implementing together with our partners and that are present here in the hall, with our communities, with our other national institutions on the implementation of screening programs on the community level.
Зараз я зорієнтуюся. Ми сьогодні вже говорили
So
багато
we
про
mentioned
ці
today
методи
and
побутової
heard a lot, and we know the
здоров'я,
information
це
about
здоров'я.
how important
Що майже
NCDs are,
більше 70%
that more than 70%,
80% людей
almost 80% of people are dying from non-communicable diseases. So we've learned
боротися з інфекційними
to fight
хворобами,
communicable
вчитися
diseases,
бути на зміну.
effectively fighting them,
Але не
conquer
інфекційні
them,
хвороби,
but
як
non-communicable
зараз
diseases
у нас
as
в
in
Україні,
the whole world as well as in the
залишаються
country are still
серйозним
staying
викликом.
a significant challenge, complicates the challenge, the influence of war, the system disruptions, partial or full, especially in the where military action took place or where there was a combat line or the front lines, and also the communities where a lot of IDPs has moved to.
Що я хочу сказати щодо нашої роботи? Метою
And
нашої
so there's a few things that I'd like to mention about our work. The objective of our project was the support of deoccupied communities and the support of communities where the biggest number of internally displaced people has moved to, because we understood the issues that those communities had on the absence of health facility, absence of health workforce, disruptions in health services provision, and also the load that additionally communities has faced with when a lot of people has moved from other regions. And so the main objective of our project was to provide for the accessibility of care for the population and to make it as closer to the place of residence of people as possible.
Ми сьогодні почули дуже гарні доповіді, і дійсно
We've heard
сказати,
a
що
plethora of great presentation, and I'd just like to say that we have to be proud that we have great laws and great policies on the screening, on the detection of main and communicable diseases. Ministry of Health is going hand in hand with the evidence-based medicine, timely updating all of the requirements, policy, and standards in health. National Health Service of Ukraine is also providing for the funding, as you've heard, the presentation, contracting of health facilities for medical services provision. Public Health Center is doing the analytical research, coordination, epi-surveillance. And so we can also have a look and see that the system exists, a system functions, but doesn't cover everybody. The proof was from the previous speaker, from Natalia Husak, was the data provision that the screening is not being used. And at this stage, we're having our story coming forward. The story about what was done throughout the years. The project started with the initiative to communities in different regions of the country, which was 10 regions, 10 and then 11, and then we have 13 communities. So we have called them in the beginning of our project the screening points, and then this has been transformed as medical care or support in the communities. But at the beginning of 2023, we have found such a name, agreed upon it, and so went with the initiative to the leadership of communities on the establishment of such a point of care. We had 3 stages of implementation. We were not able to implement this in 16 communities right away, but we've started from 2023. The communities have been deciding how many screening points will be located, where they're going to be located, how are they going to work. At the beginning, we wanted to do it in a way so make all of the screening points in non-health facilities to make it closer to people, and so that there's no syndrome of like being afraid of healthcare system. But in practice, it turned out to be they need to merge this idea in medical facilities and non-medical facilities. In the medical facilities, they have they were decided by the health systems and local communities. Those were the health centers far away from the health facility, when there's no access to healthcare. And then based on the local ambulatories, so fellowship obstetrician point, and now there are centers for health or health points, healthcare provision point. But we have a great initiative to establish those screening points because of the local activists from communities that are also present here today, and you'll have wonderful opportunities to talk to them and tomorrow as well, that took such a volunteering activities upon themselves and open those screening points in libraries and village clubs and the employment centers and social care, social services provision. So when we share this experience at the conferences and between other communities, there's many questions coming to us. And how did you manage to do that? How were you able to reach such a result that you included non-medical workers for that? And I would just like to say that in our countries, we have many activists that are ready to do something in the communities together with the health systems so that we can take care of the health and well-being of the inhabitants of those communities. And you can see on the slides that around 19%, those were the screening points that has been located in non-medical facilities. So there's 234 screening points has been created, and 45 out of them have been in non-medical facilities that has functioned successfully. Yes, they were working in tight cooperation with the health facilities, but together with that, people it was a great pleasure visited those health facilities and have received their services on screening. And I would just like to say that it wasn't that easy or simple at the beginning to involve citizens to screening because first and foremost, the word screening wasn't clear what was meant by this. Even now, if you're asked your population when you get back, well, not you, but whoever didn't work on that before from the college and ask what screening is, the population doesn't really know. And so we've started we started to increase the health literacy. So there is this so that the awareness of the population that this is just activities and early detection of any kind of conditions or disease. And this is free of charge. The project has stuffed with equipment, provided everything that's needed. And the idea of our approach is that we did a comprehensive screening in one point of care to the population, so that the instrumental screening has foreseen the taking the blood pressure in, because as you know, the highest level of mortality is from non-communicable diseases is caused by the cardiovascular conditions. We took the blood glucose level because diabetes mellitus is an important issue for the government. And also we have a survey on PHQ-9 questionnaire, which is in accordance with national requirements on the support and mental health of the population and the assessment of the level of depression and referral and as well. So we have covered all of the needed oncological diseases, but this was as a questionnaire on the risk factors or the symptoms for that the person was supposed to have was that or another kind of condition. To unify our line of work, the project together with the family doctors developed algorithms for actions, the screening, so that in any place of screening, everybody would have the same understanding what to talk to and what to mention towards the population. So we also did the unified and anonymized forms for data collection so we can assess. And today we'll partially present the results, and even tomorrow we'll have the presentation on the cascade for screenings. Or we couldn't bypass the village and rural population and the vaccination about the diphtheria and tetanus that is really important for the health centers, and to receive the vaccination in the past 10 years, or revaccination essentially. So we have also conducted the questionnaire. We did not cover all of the vaccine statuses, but we just reached out to the population. When was the last time when you have received the diphtheria tetanus shot? And if they didn't have the answers provided, then they were referred to an ambulatory so that they could be able to receive their vaccination time. So in one visit, as you can see, a person was receiving a few services at the same time. But when this system started to function fully and we saw the influence that we were having, we were able to integrate into those screening points from the end of the 2005, the screening for TB, take into account the government approaches that the community is free of from TB, and also we've added the diagnostics of chronic or COPD. So, and TB screening was done in all the communities that was done. So the screening of the chronic obstructive diseases we started to do from two communities, which is Melnitsky and Hrodenke community, so that we can check and see in practice, like, is it gonna work? Is it not gonna work? And it did give great results, because as you all remember that we have 5 main non-communicable diseases that are having the biggest burden for the government in the world, which is cardiovascular conditions, which is what else? Diabetes mellitus, what else? Oncological condition or cancer, COPD, and mental health, right? And so if you have a look that we have covered all the areas of work apart from the chronic obstructive lung conditions, pulmonary conditions. And so because of the project, we were able to implement this line of work on the community level. We are grateful to our consultants, were projects that were included there, and the communities themselves that were the first one in the line. So now we are working to scale this up to all the communities that are cooperating with us in the project. And the sanitary education, which is the main thing that every participant of screening points has received from us, a leaflet on every non-communicable disease, what that is, how to take care of blood pressure, how to take care of blood sugar level, and we're able to participate and control their own indicators and the algorithms of actions, and so many other pieces of information that was motivating them to take care of their health. And also, as we as the participants are actually sharing with us, when all of the fields have been taken care of with the prolonged winter nights, they were reading our leaflets that we were grateful for. Regarding the groups of people that are visiting our screening points, and so they're mostly women 60. The mean age is 56 years of age. And then I would like to say that we started screening not from 40 plus, but from 18 plus and over, because there was a need for that. And because there is the NCD is getting younger, and you can see on this slide that 70% from the people that were reached out, those were the people under 40. And so we do want to point your attention to that groups of people. So we've started off with a simple idea, and let me remind you, to get to every inhabitant or participants, to get medical care closer, to make a screening, and if the person has any kind of distortion or anything else, to refer them to the health facility, hoping that they will reach the health facilities and they will have the diagnostics made, because the government is providing for everything, and so the treatment as well and observation. at the same time, but it didn't came to be as we had hoped for, and we saw that we were losing people. And the first question in the conference was, do you think that everybody's reaching family doctor? I don't know what your answer was, but I think that we will be able to figure this out later. But most likely we will have the same idea that not a lot of people are actually reaching out to a family doctor's office. So we start to think what to do if you have found out that there's a high blood pressure, they're not reaching a doctor, what is the level of mortality, and what are the negative indicators are present. So by making this first step, we started to think about what is the step two, and then we were looked at the recommendations of the WHO that we were able to fulfill before, and then there has been a referral to a family doctor. And so we were thinking about the different things that are possible to be done there, but the two community, which is Yahoo community, they themselves figured out that if you connect the screening points to the health information system and the villages, then you will be able to track whether the patient has actually reached the health systems or not. And so there has been an initiative because of the leadership of the project that has supported us. So we have procured 160 laptops, and don't think that we are just release something. This is the fellowship position point that did not have any kind of computers before. So in Bullet Trace, they had computers, so we have calculated everything that's needed. We have procured laptops, and the only thing is that the local authorities has been to connect them to the internet. You know, this is an issue, and there's some level of communities. Some of the communities can have the internet, and some of them are not. But we might not be able to get it. But at times with the modern technology, so that it's not impossible for the ones who wants to do something. So they did it, and then we had issues with the having nurses connected to the place to work, because before that, for the only family doctor space, we were able to do that. But we learned the system, and we understood that this is possible, and that way, as of today, we would just like to share was what we've encountered. All the screening points that are right now are functioning in the house facility, which is 141. They have been connected to the internet in any village or rural areas, and they have nurses have access to the medical information system, the health facility, and they can track the patient pathway. And so because of that, we wanted to show you how many results we were able to get in the primary screening. And tomorrow I'll tell you about the cascade and those patients actually reaching out to them. As you can see on the slides, that we have conducted more than 140 screening activities and research and questionnaire and other things, so that you can also see that almost 32%, 34% of people with the high arterial blood pressure. This is more than 140 over 90 when you need medical assistance right away. And what was news for us, that this is not all the people who were ever first diagnosed, and then there was a smaller percentage before, and then it was around 9,000 and other groups of people, which is the population that knew about their blood pressure, but did not take medication and did not follow their lifestyle and other things. So this was the taking into account by us. And there was a percentage of coverage for diabetes mellitus, which was also high for us, and it was 17%, which is
And then almost 15% of people had the elevated blood sugar content. About half of them were initially found, while another half were not naive. They were diagnosed before and were supposed to take medications to control their blood sugar. But again, here in the slide, you can look at all details of the numbers regarding the cancer as well. We surveyed about the most recent screening date, and you remember information shared by NHSU and compliance with the Executive Order 504, remembering about all of the risk factors to be observed. Speaking of immunization, about 15% were referred to immunization, and here you can see that based on the results of the survey, about 10,000 people were referred for additional consultation to a mental health or primary care physician. And these were the cases when the health system prevented some negative consequences, sometimes preventing suicide as well. Now, TB and COPD. Again, you can see the numbers which are quite prominent in the slide. And these results are prominent enough because over a couple of months, namely thanks to performance of the screening sites, we identified 10 cases of TB, 43 total across all of the Hromadas. And also there were some cases when local nurses visited personal residences of the patients who could not come to the testing site for the sake of sputum sample collection. And also the new cases, some complications found. And again, these were new cases of the people who did not even suspect which problems with health they actually were surviving. And thus, once we look at this capacity bundle between the local and regional and national level, bringing all of those puzzle pieces together and reinforcing this with the project capacity, this all produced the results that we are happy to report. And again, response when people come with the symptoms. This was also one of the major problems, because people did not understand why they should come to screening if nothing hurts. But the question I'm always asking in our trainings, but when are we visiting a clinician? And these are only rare exceptions when somebody suggests that I visit my clinician for the sake of prophylaxis. Not when it's itching or stinging slightly, but when somebody is not moving appropriately at the stage when the body can no longer sustain. And that is way more advanced stage of disease when the early diagnostic will be functional. So again, health system, non-medical systems, they have to be working hand in hand. On top of that, we need peer-to-peer approach deployed purposefully, encouraging people to come for screening, the more so that in one visit you can screen for a number of non-communicable diseases. On top of that, the screening site can provide a referral to a clinician that would be convenient for the patient and the clinician. This can be traced later on whether or not this patient actually presented at the appointed date and time. And this would be part of the health literacy, helping us to removing the barriers that we discussed earlier. And probably finishing my presentation, I'd like to emphasize how important the role of communities is once again. At the beginning, we invited healthcare professionals to our trainings, but we realized early enough that unless the local community representatives and chiefs are invited to the same trainings, then we never accomplish the results that we set as our targets and goals. And we truly appreciate the preparedness and commitments of local communities, local self-governance authorities, volunteers who also donated their time, their passion, their effort in order to make sure that we can reach out to the people and invite them for screening, because that is critically important. And also, this model that we presented is fully functional. It has been piloted and tested over the period of 2 years, and it's really working. And it's really capable of scaling up. And scaling up is one of the results that we expect from this conference. We're also aiming at better communication and cooperation with the PHC, the National Health Service of Ukraine, engaging other CDCs across the regions and communities and other local communities, making sure that this technique translates into reality, real-life reality and health. Thank you for your kindest attention. Thank you so much, dear Galina, for your presentation.
Дякую. Дякую.
Thank you once again.
От все, що ми щойно почули,
And indeed, everything we heard
працює в реальності.
improves our understanding of this model, how it lives, how it works in reality. There is another important element, although, which sometimes is left behind the scenes, and that is infection control. It's something unnoticeable, but without it, the system does not work in such a stable and reliable manner. With that, I'm happy to invite Roman Kolesnik, the project manager from PATH, to describe some of the key gaps and actual solutions which can be implemented in practice. Thank you so much, and I hope that I will not burden you with excessive information, appreciating that we have a lunch break coming soon, but some of the key bullet points regarding the infection control to be implemented in your communities, which is particularly related to each and every one of us, especially at the stage when you have performed the screening and you have a patient visiting your healthcare institution. And thus, speaking of infection control, we do remember that control is the key word here, but majority of us, especially representatives of the senior age category, we do remember the function of sanitary and epidemiological control service, but infection control is not about control. This is more about infection safety. And speaking about infection safety, definitely we apply this notion to healthcare professionals, and also infection control should protect them first among the others, but also we should not forget about visitors who come to visit those healthcare professionals, which means that all of us, without exception, have to abide by the rules of infection control, because otherwise we become patients. We become patients of our own health institutions where we work. And thus, when you visit a local community and you see the local situation as you have it, and then you remind yourself of the importance of abiding by the rules of those infection control, you can ask yourself a question: what can I do? Remembering about all of the conferences and webinars about using the ultraviolet radiation, ventilation, fancy equipment installations, which costs $1 million per unit, on top of other problems that we have. And such questions have very cheap and effective solutions and answer to, and that will be the purpose of my presentation. Let me suggest starting with hand hygiene, basic water supply, cold and warm water supply in your public utilities will improve the infection control situation tremendously. And again, that be critically important not only for the benefit of infection control, but also the overall public safety. So do not forget that once you are doing something, we emphasize this number of times, you have to teach how to use that appropriately. COVID made sure that we learn this lesson, but we forget those lessons soon enough. So we have to be reminding ourselves about the importance of due hand hygiene, including hand hygiene options to be made available in public settings. With all of the reminders and instructions made available, you do count your money, and we do understand the clear statistics, which was presented by the World Health Organization. And here you can see that based on some estimates made by WHO, which states that every dollar invested into hand hygiene results in $24.6 of savings by means of preventing the diseases that will not break out in that community. So the investment is small, but the yield is great. Let's go further. Is this picture familiar to anyone? I believe anyone is familiar with such a picture. And any one of you was a part of that picture whenever visiting your local primary care provider or outpatient care facility. And you've seen crowds of people queuing up in the reception area. And in the context of our discussion about the importance of infection control, we do not quite obviously see what is happening inside this space. And inside this space, there is one process going on, which is transmission of pathogens. And if you believe that such is happening only during the season of epidemiologic outbreaks, then I have to disappoint you. This happens every time. Every time, because at each and every time, there is at least somebody, at least one, who is sitting there in this queue, and that would be a person from one of the risk groups. And what happens next? Once you are exposed to that risk, one way or another, everybody else is contracting that same disease, some in a mild form, others with complications, and respectively our health system will be overburdened with the number of severe cases, because here you will have people who contracted the infection, and these people are from a risk group. So the best and easiest thing you can do, but sometimes this is very difficult to do, that is make sure you have a system for appointments to avoid having such crowds of patients in your waiting area. And indeed, this is the matter of setting the rules and teaching the people how to abide by those rules. Where and why does it work in most cases in other countries in the civilized world, but in Ukraine it does not? Well, in my opinion, this is lack of training and patient education. And thus, we have patients who are angry, who push forward, walking on the heads of other patients, making sure that today they are making this visit as they planned. But if you set clear rules and you make such appointment a compulsory element of your operational management, then respectively the number of people in the waiting area grows smaller, the number of infections grows down, and your statistics improve. But on top of that, we have to understand why some patients don't want to come to healthcare facilities. They are led by superstition that they will not be serviced properly because of lack of time, because of a lack of capacity. Sometimes they present having an appointment at 1 p.m., but because of other people preventing them to come at the appointed time, they actually see the doctor at 5 p.m., and they don't want to survive that experience any longer. Nothing important to discuss will be the operational workload. The greater is the pressure of such operational burden on your staff, the greater fatigue there will be resulting from that, and the more personnel will be migrating away from that location, again, because of the dysfunctional appointment system. And again, let's not forget about the importance of having that in the outpatient setting, but equally enough about some operational management in the inpatient settings, making sure we have enough staff, enough medical nurses among that, because once we understand that comparing the situation to performance of firefighters who have to fight 5 outbreaks with the same unit, then respectively, while you are fighting 1 fire, 3 or 4 others will burn the property to ashes. The same happens in the inpatient setting. If you have too many patients, you don't have enough staff to manage all of the cases. And thus, respectively, HR availability and capacity is critically important. Respectively, looking at the statistics, we can see that staff availability in healthcare settings is very low. Please pay attention to that regarding the situation in your communities, because if you have one nurse servicing 36 patients, which is Ukrainian average, then she has no time to wash her hands while attending to different patients. And again, this brings us back to the importance of hand hygiene as part of infectious control because of the excessive patient burden on every nurse. And when we ask a question, what can we do in order to increase the HR capacity? So let's look at some statistics. If health personnel availability in a facility is less than 80%, then discussing any quality of care is not possible at all. If we look at Ukrainian statistics, then HR availability is slightly above 52%, which means that quality of care is challenged. Equally to that, the infection control is challenged. And in that context, I don't want to focus on some matters of general nature. You can learn about that in greater detail, and I'm not the expert in the field to discuss them here. But speaking of occupational safety, there are some important solutions I'd like to suggest. First of all, get them immunized. Help them to get vaccinated, especially at the time of outbreaks, especially seasonal influenza. Do pay attention to that. Based on research data from European countries, we clearly see this as a solution for saving health of your healthcare providers and staff. Make sure they are functional to service other patients. And thus, if you have such opportunity, and I hope that you do, then do immunize your healthcare professionals against influenza, other infections, including hepatitis B, just to make sure that you have enough staff to offer services to your patients. Do communicate with the management of facilities. Do encourage them to vaccinate their staff. And last but not least, in the context of infection control, we've been referring to non-communicable diseases as an important element of health and well-being. Thus, do pay attention that statistics that we have as of today clearly suggest that in Ukraine, antimicrobial resistance, and again, these are approximate numbers, because unfortunately we don't have access to full statistics because of the war, but on average we have 65,000 people dying because of AMR. And again, cancer and cardiovascular diseases result even in greater mortality, but looking at the WHO data, which currently is over-optimistic, as many of us believe, when it comes to Ukraine, then by 2050, this number will be equal to the number of mortality cases resulting from cardiovascular diseases, which means that AMR is the major threat. And that is demonstrated in the official resources of the WHO and Ministry of Health of Ukraine. So the question is, what can we do in local communities to help such antibiotics for the future generations? Respectively, we have considered this situation from different perspectives, and in our opinion, and also this is the functional solution, and that would be training for children. Children in secondary schools, middle and senior grades, making sure that in the nearest future they will be using the antibiotics appropriately. Because unfortunately, all these initiatives regarding the general public awareness campaigns, such campaigns are not as efficient as they are intended to be, and awareness is not improved significantly. And because of that, we are suggesting, just in case you have such an opportunity and such willingness to do so, then respectively all of the informational materials are available at your local CDCs. Use them to teach the children. And thus you will be teaching not only the children, but also their parents.
Parents are usually learning with children, so you'll be covering the audience that are using the antibiotics the most in Ukraine without like regular health facilities. And hopefully that together, and first and foremost, because of the communities, we will be able to preserve our health, preserve the health of our population, and of course, I wish you all to preserve your health personally, because we are also a part of people who are organizing and providing medical care in the country, and we have the right for health. Thank you so much. Thank you so much, dear Roman. Thank you so much for your presentation. I think the applause is the format of the presentation, is how beautiful it is. But we have lunch in front of us. But before that, there's another question for you. Therefore, pick your phones. Let's, before the break, scan the QR code, and we'll give you an answer in the same format for the question number 3. The main losses of patients are happening after the screening. Yes or no? Scan the QR code and online and pick the answer yes or no. Main losses are happening after the screening. Yes or no? So far that you're giving the answer, I will announce what are we going to do in the nearest hour. We're still having lunch and having a break, but in the beginning, this is not just the time to rest. And please also visit and look at the photo exhibition, which is the story of the community that are showing how their approaches are working in practice. And our participants online, you would also be able to have a look at this photo exhibition. Therefore, please stay with us, don't turn it off or anything. And then everybody who's here, please visit the photo exhibition yourself. I see that before the beginning, a lot of you were able to do that. It's in the same place in the catering area. Therefore, I think to make a wonderful picture there, it's not going to be against your interest. So hopefully everybody have given the answer, then we can go and have a break. Let's put our watches right now. It's 12:24. And in an hour, a bit before that, I'll be waiting for you to start the next portion of our working day. Have a nice lunch and then have a good rest. Thank you so much.
Пані та панове, запрошую все ж таки активніше повертатися. Час уже говорить про те,
Ladies
що
and
маємо
gentlemen, we can get back. It's time
Тому
for us to
чекаємо на
start.
вашу
Therefore, we're waiting for
думку.
everybody for a minute or two, and we'll be beginning after lunch.
Так, пані та панове, домовлялися. А я ще бачу
Okay,
дуже багато
ladies and
вільних
gentlemen, I
місць.
see there's still many open
Такої
seats
частини
and
нашої зали.
a lot of
За
people still
30
resting.
секунд
So, okay,
розпочинаємо.
30 seconds and we'll be starting again.
Так, ну що ж, пані та панове, ласкаво просимо знову.
Okay, ladies and gentlemen, we welcome you to the working part of the meeting. No matter how long the lunch is, it's never going to be enough. Thank you so much for everybody who did everything and finished everything and sit down with us. And who's not here, please get back because we're starting the part two. Continue to do your work. And whoever's here with us online, yeah, it's really nice for such a high interest for today's and tomorrow's meeting. So today we mentioned a lot about policies, approaches, and instrument. And the screening system, it's not assessment what is declared, but it's what is easy and how well the services are done. And the topic of today is movement from policy to practice. And if the decision is working, and if or not working, then it's either working or not working altogether. Therefore, the main question of our first discussion is going to be there. Where exactly does the system not work? Even though if people are just not reaching to the diagnostics. And then the most important part, what is needed to be done, what is needed to be changed so that the system would work as intended as the one singular pathway for a human. Under Euro Plus, we'll be welcoming our panelists, and you can start applauding right now. Natalia Husak, the head of National Health Service of Ukraine. We are welcoming Olena Zaporozhska, the head of the Department of the Prevention of Non-Communicable Diseases of Public Health Center, Ministry of Health of Ukraine, welcoming Yana Terleva, the head of the TB Management of Public Health Center, Ministry of Health of Ukraine, Katerina Hamazina, the head representative of PASA Ukraine, and under Euro Plus, welcoming Andrei Storonsky, the head of the Primary Health Center, Vanchi City of Volyn Oblast.
Та, пане Андрію, будь ласка, займайте своє місце. І ще раз вітаю абсолютно всіх учасників цієї
I would like
дискусії.
to welcome all the participants of this talk. Some of you have been here, and we are welcoming a few of you here today. So let's start from Olena. So we've seen today a lot of information and different data and different presentations. And if you're looking not in the system through the where specifically are we losing the most people in the cascade? So what is standing behind those numbers? And what can this be? Is it organizational barriers or human behavior? And the main question in all of this, so what needs to be done so that the patient would not be lost between the screening and testing? Thank you so much for the question. I guess in the beginning, we need to decide upon who is the patient. Is the subject of prevention or an object of prevention and screening? And our objective is to do it in a way so that the patient become a subject from all that. And if they would take active participation in screening and prevention without giving this to a health system. This line of work is supposed to be continuous. This line of work has to be going throughout life of the patient. We can start off from the maternity ward, or we can start from the moment and how in the community is doing family planning when the newborns are being born in the maternity wards, and then the kindergarten. This is the continuity in the kindergarten and training in school and adult life and work and a safe working space. So if in this cycle there's no gaps, then we have an active and continuous longevity for every person. And then we're losing people, as I mentioned before or in the beginning. Unfortunately, we are losing them at every stage of the way because we don't have the continuity provided for. And by getting back to barriers, this is also individual barriers. And as I mentioned, no matter how developed the health system is, no matter how well the services are provided in Order 504, and if there is in even most developed countries or in the most developed places in the world, if you have the full medical care provided, we still know that at least 10% of the health determinants are how well developed the health system is. And 50%, for example, of the health determinants is the behavior. On the individual level, if a person doesn't have a sufficient level of knowledge or health literacy, if the person doesn't understand how does his body functions or her body functions, if you're not helping to develop this literacy, we're not just losing, we're not going to see this patient or this person at the screening, and we're never going to see them in contact with the health system. They're just not going to be trusting official medicine. They're going to be taking information from different sources, but not from the evidence-based sources, and we'll be asking ChatGPT, and neighbors will buy medication that they're not prescribed with or
There's also another barriers in the individual as well. When in the family, there was no stable practice of reaching out to a doctor's office and any kind of invitation that they get through eHealth system or through Dia app. The person's just not going to be referring to them, and those urges of the health system to get in contact or get their attention. So additional barriers in which stage are we losing people at in every person. This is on the level of community as well. So by getting back, if we have all the legal documents, and then the communities are not providing the level of access, in the rural communities, and they don't have an access of a person to their doctor. And on the working day, today we mentioned that if a person is fully employed, that they can't during work hours, unfortunately, get into the family doctor's office to get screening. And it's a great thing that now the health facilities that have those packages check out for 40 plus, they're changing the timeline of their work so that any person would be able to get into that facility no matter the working hours that they have, but also the distance that they have to cover from patients to a health center or primary health center or other health centers. This is also on the level of communities can be done and can get the patients closer to the doctor or doctor closer to the patient. We see in many communities they're doing it that way, and they have mobile screening units and regular mobile medical units and even secondary care in a mobile setting. So we are finding the barriers and giving the opportunity from screening to diagnostics to bring the patient. And then on the level of community, the big meaning is not to lose the patient on the level of prevention of and then screening and then treatment. This is also how you organize the healthy community approach, which was mentioned by my colleagues. If, for example, this is not going to be significant inputs from communities, if the platform for doing sports are done or the free of charge, and there going to be access to the playgrounds where you can do sports in every parts of the community, and small children will be seeing the examples of adults that adults are taking care of their health or their physical well-being, then every small citizens of Ukraine will be able to take this upon themselves and take this experience and then the level of the system so that we will not be losing. Well, this is as Tatiana had mentioned, that we any kind of order of Ministry of Health is not going to help a person if the whole system is not going to be working on that. So the orders are great, it's regulated, but the person is just not reaching the doctor's office because they're thinking they don't have the systems. I'm not gonna have a doctor or the nurse that are working with the family doctor. They're actively are not involving this patient, or they don't have the stimuli and the nurse or doctor to do that, or the medical institution don't have the stimuli to involve their population more actively, not to report for something or not to just put a tick in the reporting form, but we see on the NHSU data that people are not getting referrals for the screening, and when they're coming, they're not going there because actively they're not getting the population involved. And unfortunately, I'm speaking about issues, but we can look at them from the positive point of view. If every part of community and a big role in this is also leadership of communities. If the head of the community understands that the 1 hryvnia of investment will bring the wellness and goodness for the population, that we're not going to lose our people altogether in the pathway from prevention to screening to diagnostics and treatment and the future support for them as well. Thank you so much, dear colleagues. There is such a discussion in any moment of time. If you want to add anything, you can always do that. And also, Yana, let's get back to you. It's almost the same question, but just looking at TB specifically. If we are speaking about TB, Is this like a separate issue, or is just the same system-wide barriers or something in addition going on? Thank you so much for the question. And by speaking about TB, I guess the first thing that comes to mind is because of this idea of TB as through the magnifying glass, you can look at all of the achievements of the health system and all of the disadvantages of the system. Why? Because TB is a classical condition to solve which and to influence which there is a whole list of factors, and the medical component takes almost the least prominent roles. International assessment national experts are saying that to solve issue of TB just by solving medical things, we can influence only the 10% of the issue. Other 90%, this is other areas of work. This is social component, economic component, humanitarian, educational, cultural, and others. And therefore, if in the country there are issues of TB, then this means actually that some disagreements or discrepancies are present on all of the levels. This is why TB is saying that this is the general picture. Then there's many. If you saying if there's TB in the country, then you might have like an assessment of the country of what is happening there, just if they have TB or not. This is why it's important to solve TB for a comprehensive approach, that intersectoral cooperation or a big number of groups of people or players to experts between whom there are discrepancies, but together with that, by speaking where the system actually breaks, I would say that the first thing that the system is there, so it exists. If you're speaking about TB, in my opinion, this is one of the diseases or conditions where you have the big comprehensive list of approaches, because to solve the TB issue, we can remember at least for the past 2 years, and those are the years when we are fighting TB was in the full-scale invasion. We have an updated version, the modern version of the law on combating TB, but the government is showing a signal that the will of the government, even though the war is going, is to remove TB as an issue. And there are things that are done on the highest legal level possible. And then there's also a comprehensive strategy. When you have a comprehensive approach to the nosology, they have the biggest influence, which is TB, HIV, where hepatitis is. They're usually going hand in hand up until 2030. There is a roadmap from the government on how you move forward so that those conditions and diseases will be under control and be combated. The next thing is the orient for the medical TB component, so that the strategy of TB service development, which is also a midterm perspective for 3 years. There is a pathway, specific tasks, objectives, target indicators, so that was supported with funds, so that it's clear where specifically both to medics and communities can move on to fight TB. And in the same way, if you are to take a look at the standards of care regularly, they're being updated. To 2023, there is a new standard of care. Right now, it's also being updated. So every 2 to 3 years, as soon as something new, something novel is happening in the world, we are doing this together with Ministry of Health, and we are bringing this into the country. So many changes can happen in the area of work that when we just entered this, we have prevented TB, for example, we have protected from the development of TB by giving preventative treatment by half a year, and then there's 12 months regimens. And so right now, not everybody remember, there have been even 36 months regimen for prevention of TB. And sometimes patients were saying that it's so if I get sick, it's better for me to get treated for 6 months and not to take something for 36 months. This is happening right now. Right now, there's 1 to 3 months regimens with modern medication that is also are being used, and intermittent and other options that are more adapted to the needs of the patient. And treatment of TB, I came from the resistant TB was treated usually 22 to 36 months. Right now, the resistant form of TB, if the person is timely in encounter with the health system, they're being treated by 6 to 9 months. Sometimes it's longer based on the certain conditions, but how deep structural changes had been and happened, that there's so much of what his system done that is this general jigsaw puzzle that is showing that here the approaches are working. This is from one side. From another side, we're looking at numbers, and those numbers unfortunately showing us the other side of the medal or the coin. If you're looking at the detection, we can even a number of factors that is really hard to analyze that are really have a strong influence to assessment, international assessment, national assessment. We can pre full-scale invasion. Before the war, WHO and our national experts were showing us that every third case of tuberculosis is still undetected in the health system. Let's look at different numbers. Almost every 10th person with TB that had started and are receiving treatment from TB is being lost before the ending of treatment because there's no treatment. And so there are specific factors and facts that are showing that in different stages of care, system does malfunction. And let's see what can be behind this. From one side, what I would say is that, is what Olena was saying, that not always aligned all of the medical elements of the health system. Sometimes there is a disruption between primary care and family medicine and specialist care, not always the patient that had the possible TB as a diagnosis had actually went to diagnosis and treatment. There was a line waiting for CT, or the patient did not, the diagnosis were put, but did not inform the patient, sent to TB facility, but the person might not have funds to get from the village to a regional TB center where the diagnosis can be confirmed, and not always by the telemedicine or any other opportunities may actually work. So those kind of factors that are actually putting there that there's such a complex epidemiological situation has not yet been solved, and so that to get in depth and to understand like what stages something's not working, there has to be a specific patient pathway. And we in our activity at the public health center, we're visiting health facility, and every time I'm trying to walk the patient path that is approved in your facility to walk through this, and unfortunately not always I'm able to do that.
And thus, once again, these pathways should not be only described in paper. They should be realistic, they should be updated, they should be flexible enough to include these multiple referrals, making sure we are following up with the patient. And another important factor then the desk review that we and the inventory study we did with WHO a couple of years ago. Yes, a couple of years ago, but its results are still relevant enough. They clearly suggest that about 10% of patients with TB found they never make their way to the TB clinic because of objective or subjective circumstances. And our objective will be to bring these jigsaw puzzle pieces together to a complete picture. Next would be the innovations, scaling them up and making them accessible. Thanks to all of our donors, supporters, United States government support, humanitarian partner support, we can innovate, we can pilot, we can scale up the successful pilot models. But next to those innovations, we still have some conventional approaches. We have just finished the annual monthly event, 1 month long event of TB screening, and such big scale coverage efforts, they can be successful, but not in the context of TB. In the context of TB, we need some targeted approach, more customized, more tailored approach, which will be focusing on those most at-risk groups which are defined in our state, because these risks and the respective categories, as well as eligibility criteria, were designed in line with the evidence collected by the science. And thus, speaking of operational feasibility, financial feasibility, we have to use our resources wisely in those areas where the yield will be the greatest. And this brings us back to HR capacity. On the one hand, we don't have enough HR capacity in terms of numbers. On the other hand, we come back to photofluorography, big-scale interventions, which have almost been abandoned a decade ago. So again, we can see that the system is not flexible enough to provide complete care bundle for the patient and making sure that patient comes back into the system for the follow-up care. That has to be addressed. Communities have to be engaged there, and resources should be targeting and supporting that. This is not an individual problem, this is the matter and problem for the community to manage. Sometimes we also have losses, and every loss of a patient is a substantial loss for the system, for the economy, for the family, of course. But also, this will be an epidemiological loss because any person with TB who does not get respective treatment up until the time when they start taking medicines, such people are contagious. And based on different estimates, they can be transmitting TB to other people in their environment, and that becomes a community-wide threat. But we should not be accusing the person. We should be identifying such persons and targeting them with our care and support. And indeed, there are some people like truck drivers. They have to travel nationwide. And if we have a model that is flexible enough for them to do their job, to travel across the country for a month while having a 1 month long take home medication, definitely that will make a difference. And also preventing stigma and discrimination. We discussed that earlier. But let me quote those numbers again. 30% of people, every third person with TB is experiencing stigma. Every third person with TB is anxious, definitely, and there is anxiety to disclose their status, to disclose their diagnosis because of stigma, which is so great. Nobody wants to be associated with TB. They are scared because of their diagnosis. They don't want to acknowledge that. And then, of course, they don't want to be left face to face with this challenge that they will be facing. Speaking of examples, one of the brightest examples would be something I experienced last year. And just imagine a small town close to the front line. They are fighting for their life every day. They have everyday challenges with everything. But there is a miracle. Of course, there are some people behind that miracle. But the miracle is that a 10-year-old child was diagnosed with TB. Treatment was prescribed and initiated on a timely basis. Very good response to care. The child recovers. I meet the child in the inpatient facility, but the fact is that this is the only child for the entire inpatient facility without any socialization because everybody else are adults. And the fact is that this child could not be provided with the treatment process on community, in the local community. There was nobody to provide for telemedicine, for DOT purposes, to provide the take-home medication. And instead of managing that case locally, this child was placed in the inpatient facility of the nearby clinic. And this was summertime. Instead of roaming around, she was kept indoors. Of course, I wanted to hug the child, to support them. And again, a couple of weeks later, once the regimen is fully operational, it would be easier and you will be able to roam around with your friends. But again, looking at that child, which grows adult, I would even describe it as growing old immediately, because the child admitted that they have no home to come back and no friends to go back to. The fact is that all of the local community members learned about the diagnosis of the child, and they made sure that none of their children would be playing with a child who is sick with TB. And again, this happened last year. This community is still fighting with the aggression, and this child definitely is the example of system malfunctioning. This malfunctioning because sometimes this is difficult to be a human in such inhuman environment. And again, this child, his name is Anatoly, he is fine. He was relocated and he recovered from TB, but I am certain that this trauma will persist. There is a chance for the better future, but all children need the chance for the better future. So I'm trying to recall 2006, when I just came to this position. Back then, some of the things we did were unheard of. Тростянець Громада, 2006, and one of the discharge certificates which I was signing, and this was my patient who requested that I should produce a special certificate for him to access a local well, just to collect a bucket of water. And I had to explain that we don't have a format for such a certificate. So he explained that there was a reason behind his request. All of his neighbors in that village prohibited him to approach the public well to get a bucket of water unless he produces a certificate from the clinic specifying that he can do that safely for the rest of the village. And again, there are other people doing their job, sitting here, sitting somewhere else, watching us online. They all are elements in this system. They all are agents in the system developing and improving. But we have to think hard. What and where else can and should we do working together in order to fight TB successfully? Thank you so much. Looking at the science here in the hall, I can understand how much attention was shared with the audience to your message. And indeed, we had to work together to make sure there is no malfunctioning in this system. And with that, coming over to you, Andrei, what are the main difficulties, maybe challenges and problems in your Hromada, in your community, preventing people from successfully accomplishing the entire pathway? First of all, let me start by saying thank you to the project on account of the fact that my community, for the third year in a row, being part of this project. And when discussing some malfunctions in the system, well, first of all, we have to admit that there is a system to start with. Of course, 2 full years is not that much time to declare that we have sophisticated system in place and action. And there are challenges, but I'd rather divide them into 2 different categories. One that we as community leaders can affect, and on that note, we have to be reminded of ourselves, of our patients, of their unwillingness, sometimes ignorance about their health. But in most cases, this is because of lack of confidence and lack of perception of credibility in us as healthcare professionals. And also some results of the after-image production efforts before, just like we had with anti-vaccine campaigns. And I am not inclined to think that all of the healthcare professionals are the saints and angels, but most of them, prevalent majority, they are quite committed and professionals. The matter is that patients have to believe and have confidence in such professionals. And to do so, they have to learn about life-saving stories which do take place, including those healthcare professionals who work at the zero line and in the front line. There are other factors which can hardly be affected. Well, first of all, lack of financial resources, lack of funding at the local communities because they don't have any budget to spare to cover some of the health needs of the local community members. On the other hand, accessibility is always a challenge. Transportation, logistics, distances between different villages, all that prevents local community members from coming to healthcare facilities. We are trying to manage that via outreach actions, mobile clinics, mobile catch-up efforts, but even that sometimes is not sufficient. Another important factor I'd like to remind ourselves, again, it requires some attention. Again, speaking about the patients who got sick. Once you find the case, you have to treat that person, and there is money coming from the government to make sure this treatment is available. But how about people who do care for their health? They don't get sick, but do they get any support? Do they get any preferences and privileges? Because we believe that such people are blessed by their health, good health, and they take it for granted. And instead, we have to better understand that these people are taking a lot of effort in order to keep themselves healthy. That's a very interesting opinion. Let us make sure that we include that into the list because that requires additional discussion. But now, coming over to you, Katerina, in your opinion, why don't people come to the system even if it's available and accessible? Why don't they have this confidence? And what's more important, accessibility or confidence? Very good question, thank you. And reflecting on the opinions shared before, but before you put your microphone down, Timur, dear Timur, please let me know if you did what you promised to do before the lunch break. Did you register for the Health 40 Plus screening or not? This is not bullying. I'm not pushing. Well, I was busy having lunch. Well, the question is, why a young and healthy person should register for health screening? When we are discussing screening, we are not talking about patients. We are talking about healthy people before they become patients. And this is very difficult to acknowledge. We have different preferences at different times. And indeed, we call it health literacy. I'm not quite happy with that definition. And then sanitary and epidemiological well-being and education, bringing us back to the 1950s, setting that aside. This change takes place within ourselves, personally, within ourselves, community-wide. And just like Andrei said, this healthy person, how much attention, how much respect is enjoyed by such healthy person? Why others believe that it's normal to be unhealthy and looking at the healthy, strong, and ever young or younger than you actually are in terms of age does not attract other people to follow the same pattern. And again, resources of the community, setting the money aside and looking at other resources such as education, social welfare, let's not forget about that. Well, not that we are forgetting it, but it requires additional discussion, and that's a very important domain, particularly in the villages. That would be a religion and religious leaders, because I do remember when I was visiting different communities, Unfortunately, I cannot travel as much as I would love to, but there is one particular community that I am the big fan of, and that would be Dobrovica in Rivne Oblast, the northern part of it, which is bordering with Belarus. So this is a remote rural neighborhood, and villages are quite distant from each other. But the matter is that in that particular community, they managed to mobilize everybody, and local villagers are engaged fully. And you remember what Galina said in her message about the importance of establishing such centers, not at the facilities of healthcare, but at non-medical facilities as well, making sure it's commonly accessible, at the feldsher service and their importance as well. But again, the war has started. People started moving away from the war. We have so many IDPs. Some areas were occupied, then deoccupied, and we also are talking about specificity of other communities which are hosting those IDPs. In Khmelnyk, for example, almost 50% of the current population are IDPs. On top of their local residents, on top of the healthcare professionals from that neighborhood having migrated elsewhere. So again, they had to cope. They needed some solutions. And thanks to the science and technology being on our side, with the express tests and diagnostic tools and techniques, which can be deployed for the sake of screening before any person requires any health service. So screening is actually scything healthy from unhealthy. And as you remember, Tatiana, even before the war, we discussed this number of times, this can be achieved via communication, via counseling, and different types of local community centers, different kinds of establishments, either in medical or non-medical settings, communication, education, awareness raising, which would be customized to the local situation. These are extremely important. Further on, we have to be mindful of the local community effort. Again, I believe this will be in our tomorrow's agenda, the mental health implications. Are they ready to acknowledge it and to work with it? And to what extent this will be efficient? Are people prepared? Is community prepared to acknowledge the importance of seeking advice of a mental health specialist or a psychiatrist if it takes?
All of this is us and all of this is about us. And there's many things that are individual and such a load for the medical system. And I think that we have to be an understanding that maybe they're not going to hold that much, that you need to look for other resources that would allow us to and support people so that they would be interested to go for screening, because there are screenings that you can't go in the level of community. For example, oncological screening, some of them, and so they would require equipment, they would require expert of different profile. And so that there is a communication and support of the general atmosphere. I don't know what to call it, a different way in a community that would improve, and then we will overcome all the barriers. This is also about this stigma that we mentioned before. Now it's 30%. Before it was 100, right? And everybody was, and sometimes when those are known things that journalists are working. There was a program on the TV maybe 20 years ago and about TB as well. It was a great thing, everything is correct, and then this program is finished, and then you're moving out from your house and you're pressing an elevator button or you're opening the doors, and you have to be conscious, is there anybody from your neighbors who had TB and started from something good and then this is finished with something bad, stigma inducing? So maybe I'm not consequential in what I'm saying, but maybe colleagues can add better information. But I'm hopeful that Timur and others after the break or you will be able to do that, go through your screening. Thank you so much, and I'll report on that. I'll tell you more. Okay, Natalia, then if you go to the system-wide level, so what is prohibiting the health facility to be more active with screening? And is there a financial model to stimulate the full patient pathway from the detection to treatment?
Хороше питання.
It's a great question.
Я вже в
When I was giving my presentation, and we, as a strategic procurement agency for medical services, we have in our arsenal a lot of instruments for motivation, changing the behavior, changing the provider's behavior, changing patient's behavior. During the time of the program for medical guarantees existence, I guess we have used a lot of instruments to encourage behavior, discourage the behavior, to change the situation. As an example, if you're speaking about the screening of people from risk groups, apart from just this was decided as a procurement objective and was put in the capitation rate that we are paying the services for the primary care. And by starting from that, we urged all the Ukrainians and then to have their own family doctor and to form a trusting relationship with them. And so we also saw that we are ready with time to move to the payment for results, to motivate family doctors to be more proactive, to work with people of the risk groups. So we've tried to implement this in 2024 and in 2025 as well. In 2024, we did not have any primary care providers that would cover the rate that we wanted to add for risk groups payments. And we understood that, okay, for us, it's not important to have in the specific case in this instrument and the amount of funding. For us was important the result and the usage of this instrument. And so we have reduced the bar, put the bar a bit lower to pay 2025 and hard period for primary care, because we did the verification, we did many things and used many instruments on the effectiveness of use of funds. But together with that, we accumulated the pool of funds to pay for efficiency indicators. And so only 33% of primary care services providers have received in December of 2025 the payment for effectiveness of work and working with the risk groups. But this is not small funds. This is over 350 million into the development of those health facilities at the end of the year, so that to show and improve that the motivation is working. From other side, we have seen also that we have for a few years already the health reform. And what we are seeing is that in this complex, harsh environment, despite war, despite the big mobility of the population, we're seeing the pool of patients that have not ever reached out to their family doctor. And in that group of patients, we saw, in that number of patients, what we saw is two big categories, which is children, that has to be also covered by at least under 1 years of age, at least by 4 pediatricians or family doctors. It's also risk group, and in other risk groups, people over 40 in the order number 504. In a table, it says that this is the age group is a risk group. And so we also seen that we have a big number of Ukrainians that are in the age groups that are throughout 3 years have not ever been in their family doctor's office. This is why we've started to use the coefficient of encounter, which is different instruments that are stimulating through the use of decrease in funding. So if you don't want to lose your funding from the National Health Service of Ukraine, then please get in contact with your patient. So when we're using such an instrument, we've heard from family doctors that, oh, this doesn't depend only on us, this doesn't depend on funding. A big responsibility is on the level of the patient, and therefore, let's think of a different way how to motivate the patient. And so we went for a different stage. This is why in 2026, we do have a separate program for screening, for health screening, where there is a change in approach for payment for medical service, and also there is a motivation is given to the patient themselves, so that you understand in this case or this instrument that is saying that those 2,000 granules is not given to the health services provider, it's given to the patient, and they're motivated
motivating patients to change their behavior. This is also about the consumer economy, and this is also about the search of new approaches and novel ways. And so we are seeing that it's still not enough, and this instrument is also can be worked on and processed and used.
Є лише одне.
It's an error word, just one thing.
Тому Тому з 1 липня
This is why from July 1st, as you probably heard, the political notification from the Prime Minister of Ukraine then to have a wider reimbursement of the cardiovascular program for all of the nomenclature medication. This is just that the people from the risk group, they need to go to their family doctor with their e-prescription to get an e-prescription. And it's important to look at this intervention, financial and political intervention, in that view. And I do understand that we need to go down a level, but I also like to mention one phrase that we can look for in different approaches, options, and different level of services provider, and then NGOs, and the level of communities, and the level of the government. But I think that our country needs to have, and this has to happen in the level of community, like a healthy ambition to do more for the health of the population. Because right now, I feel like our system and this healthy ambition for most of the heads of community is to have a hospital to preserve funding, to preserve the beds and others, but not a lot of people are looking at the ambition of a healthy inhabitants of the community.
Дякуємо.
Thank you so much.
Дивіться, пані та панове.
Ladies and gentlemen, we're looking at the safety situation.
Тому, в принципі,
And so we do have a shelter on the -1st floor. If you feel like you need to go there into a safe space, then we are welcoming you to move there. And we are not going to be disrupting so far. So since we are finishing the time for our panel discussion, and to finalize it, we just like to have a more practical side of the things. This is why I want to hear from each and every one of you, one sentence, maybe two sentences, without what this system cannot work. Like, what is the crucial for the system? Your practical opinion, thoughts, or comments. Then I can start. This system cannot work without the system, without the involvement of all the stakeholders, of all the partners, and all the participants of the system. Only together we would be able to do that. And so I would just like to quote Goethe: knowing is not enough, you need to use what you know, and to wish is not enough, you need to act. And only together we will be able to push the system forward towards action. Thank you so much, Elena. Andrei, see you're taking the microphone. Please, you go ahead. I'm thinking, because we are always speaking about the patient as the virtual human being that is almost not existent, but let's for a second think and we'll imagine ourselves that we have become those patients. Can you tell me, does every one of us, all those doctors' prescription, doctors' order that they've been given to you, are you fulfilling all of them, or haven't you looked for other ways to not do the treatment and not to fully follow the treatment? And if every time we have put our emotion to our friends and families without commenting that their diagnosis or prescribed treatment to others. So this one American admiral was great in saying, before starting to build a government, you need to start to make your bed in the morning.
Дякую. Пані Наталю.
Natalia?
все є. Ми коли почали аналізувати
So when we've started to analyze all those data, we understood that the program for medical guarantees has in many packages and throughout is woven in, there's wonderful word support of the patient. In almost every package of services starting from primary care, there's always support for the patient. And I think that after this conference, at least in those communities that are having this project happening in them, the support idea can be worked on, because when I been presenting, I mentioned that it doesn't need to happen that the primary care is just staying like alone at their responsibilities or their responsibilities or authority. We can also say that patients are at fault because they have many challenges and many other things that might be happening. So we just need to start with the talk at the community level and to know who in the community will be responsible for the support function for every element that gives you an ability. And then maybe there's no ideal recipe for success, because all of us, especially now, all of the communities are vastly different, challenges are different. But I think from such a talk, this is the step one to the results that we would like to achieve. Therefore, I think where we were looking at pictures and the photo exhibition, there was also like a story that the trust starts from the talk. And somebody from the leadership of the community is saying, I just recommend to everybody to get back and to start from the talk. And all the instruments, they have been created, they are created, and you just need to get out from the child's position from every side. But what you need to do is just think and to see and encounter the horrific numbers that I've been showing and to twist them from the bottom up. How many Ukrainians can we actually save now just by starting to talk to each other and just acting along the way? Thank you so much, Natalia.
Пані Катерино, хто за вас?
Yana Katerina, who wants to go first? So I've built the political leadership, leadership at the local level, people, and then responsibilities. So we need to know where we're going. Hopefully this is when we're speaking about leadership, usually what we're seeing is the same.
Просимо всіх терміново прослідувати в укриття. Attention. Air raid alert. Please proceed to the nearest shelter.
So when we're speaking about leaders, what we're seeing is the same simple faces if speaking about medics everywhere, from oncology, from TB and nurses and everywhere else. So there is a big request to be a leader and to be proactive, because really to change the system that is going on the way or against the current, we can't. From what was happening, the changes, somebody has to take the leadership to bring people together, have the idea, the objective, and to move towards it. And the responsibility, even if you're developing wonderful evidence-based things in the local levels, just because somebody doesn't know or don't trust the system was not implemented, and the responsibility has to be on all of the levels. And the people that are implementing those changes, the people that as of today, they are really are exhausted, are still staying at their own places of work or places of involvement, and possibly are just remembering the research results on the TB that we did a half a year ago, and the results are just overwhelming. They're saying that as of today, medics from physiatric service, in terms of mental health, in much worse case than our patients are. And we need to take care of yourself. You need to understand, like, what is your pillars? How are you going on the website? Any changes are starting from oneself. So let's also, this event, this wonderful opportunity to talk to be together, to be outside, to point your attention that it's still spring and the alert will be over, and also not forget about yourself, because we are the elements of that system that has to function. Thank you so much for such excellent work, Katerina. I will try to go shortly, because as we are speaking directly about screening, that I'm sure that I'm in support for everybody who mentioned anything before me. But I would say leadership
I am in full agreement, but especially at community level, to simplify things as much as possible. And so we are always forgetting that the science is moving to using all of this science achievement. Nobody's saying that in 5 years, the screening will be done by a robot to us. And so most likely it's going to happen at some point or another, but to simplify as much as possible and to get it as close to a human being as possible. If this is going to be like in front of your face, but for most of people, it's still going to be easy to use, accessible, and this would allow us to improve our situation overall. Thank you so much. Let's give a round of applause to this panel participants. Thank you so much for everything that you're doing and for the thoughts, opinions, and comments that you made. And I think that one of the pathway for the system would work. This is also to get together, talk it through, and to look for a correct way of forward and correct thoughts. Thank you so much. So I was told that the Shaheeds were moving outside of Kiev and went on their married way. So I guess we can continue not to get out of the timing because I guess many important presentation will be on. But before we move on, let's say a few things about the format, and we'll conduct another interactive interaction. For that, you also need your phones, but don't mix it up with our two-day quiz that we are conducting. This is specifically here and now a quiz. Take your phones, and then on the screen you're going to have another QR code that you would need to scan, and in that way we would be able to get into Kahoot. I guess a lot of you know what this system is, so let's not to break the tension. So everything you need to do is to scan the QR code, and so there is a bigger group happening for them, and then I guess that the table is going to be removed and nothing will be obstructing you. And so you're getting in the game, you just need to write your name there and to wait for everybody to join. Everybody who's here in the hall or who's watching us online, you can also join in. Hopefully that we're going to have a few hundreds of us in the game, maybe even more of us. So we'll see, and just a bit of time for that is needed. Maybe now you're seeing your names popping up and then on the screen. Kahoot has been open on your phones. Don't close it up, the app, and then let it be open. Even if you're blocked the phone, nothing bad will happen. So let's just not read that happening, just stay in the game. Just 1 minute of waiting for that, and most of us can participate.
Also, if somebody has a question or problem regarding the connectivity, then check with your neighbors. We'll be helping each other in this respect as well. And I believe another 30 seconds will be enough for all of the delegates, both online and offline, to join us. And with that, let me explain what happens next. As the quiz starts, you will see the questions here in the screen, as well as in your smartphone screens, and you will have 4 options to choose. And again, this is the method to suggest your response as soon as possible to get on top of the chart. And with that, starting our final countdown, now we have 6 and 5 and 4 and 3 and 2 and 1. And here we go. All of those who managed, they did manage this successfully, and we are ready to start the round 1. Thus, be prepared. Now the question will come to the screen. Screening is a standalone service available somewhere in red, a tool for early detection and prevention of complications in blue, something done in pylons yellow, or something that everybody's discussing in green. Please choose one of the reply options that you believe is the most relevant. You have 10 seconds to answer. 5 seconds left. Time's out. Well, 132 out of 134. We have a fantastic result, 99% at least. Of course, this is a tool for early detection and prevention of complications. And with that, we continue. Well, first of all, let us check who is at the top. The Angry Fox. The Spider-Man in the second place. Evgeny, Danilo, and Jewel are in top 5 of our rating. Of course, these positions will be changing the longer we proceed in the quiz. So let's continue to another question about the key goal of the screening. Red, increase the number of tests. Blue, improve reporting. Yellow, check equipment. Green, identify a disease at the early stage and refer patient to treatment. Please choose your reply option. You have 10 seconds left now.
3 секунди.
3 seconds.
Так, ну тут теж прекрасний результат.
Okay, another outstanding result. A little bit less than 99%, but definitely the appropriate reply option would be here in green. Find a case and treat it. Let us check the chart of leaders. Yes, we have some changes. The Spider-Man is now in the lead, followed by Jewel, Danilo, Kifa, and Valeria, joining the top 5. Let's go next. Question 3. The biggest losses of patients take place at the stage of registration, red, during referral is blue, between referral and start of treatment, yellow, and following the treatment, green. Biggest number of patients are lost at one of the stages. Which one? Please let us know in 10 seconds. I can see it takes a while to produce the answer, unlike the initial 2 questions. Now time is out, and now we have diversity of opinions. Only 2 selected the option 4, 11 option 5, but the appropriate type of answer would be available in the yellow field. The Spider-Man is strongly chairing the lead. Olga K in the second position, Danilo, Ganna C, and Alexander joins the top 5. Next question. If people don't present for screening, this means the system is not sufficiently clear and accessible. People are not responsible, lack of motivation, or weather is bad, respectively, in due order of the colors and options. And again, as you can see, the bad weather is not a factor to prevent us from coming to this commotion in our conference today. And with the time running out, 90 participants suggest that either system performance is not clear enough or lack of clarity about its performance. Lack of motivation, although, is also an important factor, but the appropriate option to reply was here in the red, and we can see that Spider-Man is still at top, Olga K is still here, Kurdupel joins option the chart of leaders. It would be quite interesting whether we are about to learn who the mysterious Kurdupel is. Next, what would be the best place for screening? Any place with a table available, a place which has a respective environment for such a proceeding, separate clinician's room, or a waiting area with the flow of people. So again, the best place for screening would be one of the following. You have 10 seconds to choose. And now the time is out. And indeed, 108 appropriate options. We need a place which is designed and equipped for the appropriate proceedings, but any place with a table. And also, if this is a nice place equipped with a table, that would be indeed well fit for such purpose. But the best appropriate description of the reply option was here in the blue. And now back to the charts. Spider-Man, still at the top of the charts. Olga K. Quadruple, climbing up to the top 3. And now question 6. Screening without a patient's pathway is the first step, red, normal practice, blue, a pilot, yellow, or an opportunity lost for a system in green. If you are screening without having a patient pathway, that would be, in your opinion, please suggest your opinion using the options made available here. You have 10 seconds to do that. 5 of them left. Now time is out. 112 correct answers. This is an opportunity lost for the system. But the first step into that system also has 17 votes in favor. Looking at the top of the charts, the Spider-Man still at the lead, Quadruple declining, Olga K, Irina in top 3, and Oksana joining top 5. These are familiar names already. Let us see if this list changes after question number 7. The key problem of the early detection system is gap between detection and treatment, red, insufficient number of guidelines, blue, insufficient training, yellow, insufficient equipment, green. Again, which of them would be the key problem of the early detection system?
5.
And 5. And time is out. And here again, almost unanimous, 115 correct answers. Indeed, this would be the gap between case finding and case treatment. Let us check the top 5. Only position changing would be position number 5 with Oleg Zvegel, moving the previous contestant from the previous position. But let's see what happens next with the question number 8. Data in the system most frequently is absent in red, are collected but not used for decision-making in blue, always used in yellow, and not necessary at all in green. And 15 seconds you have. Speaking of the data available in the system, this is a real pleasure to see that even before I finish reciting the question, we can see the number of responses growing. 104 suggest that they are collected, but not used by that system for decision-making purposes, although being available. And here again, this is not just a matter of checking the knowledge. This is the matter of testing your speed, your accuracy. And also, this is kind of a social survey. Sometimes even incorrect answers are helpful to better understand the general situation. And looking at the chart of leaders, almost no changes at all, I'd rather say. Last but one question about the most efficient type of screening. That would be something covering many people in red, something cheap in blue, something really changing results for the patients in yellow, and something which is fast in green. And 15 seconds to choose one of them.
Ще 5 секундочок.
And 5 seconds left. Okay, we can see the number of responses declining. Some of the people are roaming out. So indeed, that would be something which really makes an impact. But something with high coverage, being fast enough, would be helpful. Thankfully, nobody is chasing the cost. And before having the last question for discussion, we can see that the Spider-Man is still in the lead, followed by Irina and Quadruple, but now we have Yuria and Victoria with double K joining the chart. So the final question to find the leader. Community is an administrative unit in red, place for reporting in blue, a territory in yellow, or the level where people realistically receive or fail to receive any assistance.
Це час вичерпано.
And now the time is out. And here we have a split decision. Majority of people voted in favor of the administrative unit, and there is a lot of sense in that option, but in the context of our meeting and the topic for discussion, indeed, a community is the particular dimension where people can either receive or sometimes fail to receive different type of assistance. And now let's look at the final results. And in the third place, 10 out of 10, we have Yuri. In the second place, 10 out of 10, Kurdupel, stepping on the feet, and the winner is the Spider-Man. And if we have the Spider-Man here in the hall, Kurdupel and Yuri, please rise so that we can reward you with a round of applause. And who would you be? Please meet the Spider-Man. And then Kurdupel, I am your fan. And Yuri probably joined us online, making the fast progress to top 3. So thank you once again. And a quick spoiler, tomorrow we will have a similar quiz. Please make sure you're well prepared for tomorrow. And today, thank you for being so active. Hopefully this was energizing enough to take us to the next part of our agenda, which will be dedicated to discussion of another important element of the system. And again, we'll be talking about the people who are as close to patients as possible, and these would be nurses, discussing on the role that nurses play in community and the system. Sometimes it's silent enough, maybe it doesn't seem to look so remarkable, but important yet. And with that, I'm happy to invite Hanna Chervona, director of Havrosia Kyiv Medical College, with her presentation about the role in community-level screening. Good afternoon, dear colleagues. This is my pleasure to be here with you, and thank you for the kindest invitation, because this subject of the nurses and their roles is very vital and relevant today, particularly in the context of community-level screening. For 20 years, more than 20 years, I'm working in the sector of nursing and schooling, and my message today that I'm trying to deliver to you would be in the following. If we, education professionals, will be doing our job right, then community-level screening, maybe not by 100%, but in a very big proportion of that, can be delegated to nurses, and they will be taking it forward at the community level. That would be the short version. And now I hope this fancy device is working. And I believe everybody in this hall, maybe even before, even if you didn't know about screening before this conference, then you heard something about screening. Probably you understood that screening is something greater than just a laboratory test, and there is a pathway attached to that. And the idea is that somebody has to identify a patient, somebody has to support the patient along that pathway, and also making sure that patient does not step out of that pathway at any stage. And in many cases, a nurse, or either male or female, but a medical nurse, plays that role. And speaking of such nurses and the nursing function, we do hear and learn not only about the symptoms of the diagnosis, but we also hear the patient stories, stories of despair, unwillingness, or unpreparedness to carry on along the pathway, some misconceptions, and other concerns, which might be challenging in that process. On that note, I have two rhetoric questions. To a certain extent, rhetoric, of course. Question one, are nurses prepared and capable? Do they have knowledge? Do they have skills required to assume this responsibility of community-led screening fully or in big proportion? And the next question, which will be even more sensitive, are they willing to do that? Do they need to do that? Because that means additional responsibility, additional decisions. And maybe the third question to follow up on that. Third question, referring the education professionals. Are we doing our job right? Do we have the right curriculum? Don't we continue to replicate the education format in the context of perceiving a nurse exceptionally as the executive agent for clinicians' decisions? And are we working in that context to improve this? And taking this further, begging your pardon, but there are some technical discrepancies that I'm experiencing.
Okay, I'm trying to press, but oh, now it's working. On this slide, there is a book from the library of my father. This is the book of 1911, and this is minor surgery. Future doctors were learning through the university in Kiev in the beginning of the last century. And from the first lines, it's saying, what is supposed to be the role of the nurse? I'm quoting. Nurses, good nurses are rare to find. And in this context, 3 letters, quiet, unnoticeable, the ones who fulfill doctor's obligations and has to follow to the word, no objections, has to perceive it. It says that way, and then and I guess at that moment of time it did work, but as of today, why is this so out of order? Because today there is a difference in complexity of medicine, of health sciences, and so today we have invasive robotic interventions, we have multi-components treatment regimens, and every new technology, it brings upon it tens of thousands of new routine things and new solutions that most frequently has to make by the nurse near the bedside of the patient or an ambulatory visit. And the profile of patient have changed. We have less and less urgency. We have more and more chronic, comorbid pathology, the aging of the population. It requires a different self-education, self-learning, and more of a in-depth involvement of nurses to screening programs in community levels, rebuilding patient pathways from the ground up. And when you're touching the topic of leadership, here there is a bit of a discord in my head happening. And a few days ago, I had a talk with a friend of mine who is a nurse regarding leadership qualities. And so she was telling me, you know, I feel like leadership in nursing is not going hand in hand because it's sort of like fighting for ambition. A doctor and a nurse is sort of like a nurse we're trying to reach to something. Is it like an auction of who does it better, or who's bigger, who's more powerful, who's something? And so we reached the conclusion, we got to understand each other, and the leadership in nursing, it's not really about like who's the top guy or top dog. This is not about not valuing a doctor. This is more so a type of language, I would even put it that way. If in our center we have a patient and we are saying they work in a team, then most likely we would need to speak about the fact that a doctor is a unique expert. The government has put a lot of funds and time for them to be educated. And if we are to take a doctor and be loaded with tasks and objectives that the nurse can deal with wonderfully well within their competency and with the conditions of special training needed for that, or specialized training. So this is not fair. This is not fair in terms of the patient. This is not fair for taxpayers, because the patient is waiting for the doctor a complex solution, the solutions that he have this training done for. But here it's more so about effective redistribution of work in the team. How does this system look at it? And in the government level, in my opinion, there is a strong and legal support is good. And it's all started in 2022 when the law on Ukraine on the professional qualification has been made. This law is entering the professional standard as a new term for all of us. In 2025, the law, and I'm not going to quote it, but it says that to prepare qualified personnel, continuous professional education of medical workers, and on and on. And that law has shared this whole to the health system as well from other areas of work. To work as a nurse, for example, you would need to have a professional qualification. This is not about the diploma, or not only about the diploma, and to constantly support it with the continuous professional education. And then we have reviewed a national framework for qualification. So we have a decree of Cabinet of Ministers of Ukraine in 1991. Medical nurses are having the ability within the professional education for continuous growth from the 5th level of qualification, which is the junior medical nurse, up to PhD, to candidate of sciences, or doctor of philosophy, essentially. And so in 2024, a strategy for developing of nurses has been approved. It's been approved on the level of the Ministry of Health of Ukraine. And to that, a lot of partners would be included, WHO as well. Therefore, they have 4 components: education, leadership, occupational safety, and then this strategy for 2 years is being implemented. We are seeing the benefits that coming from it. One of them, I think that it started and actively working on the level of Ministry of Health of Ukraine and the development of professional standards. And so we have a standard that is called medical nurse in the community. That standard has already went through the public discussion. It has been given to National Agency for Qualification. They have entered their changes and everything else. They got it back to the working group, and so now they're making changes. And so we're waiting for the approval by the ministry and approval by the cabinet ministers. So what does this document tell us? What is this different from the professional qualifier? It goes much more in detail, and it also says much more autonomy for nurses. This is the professional landmark for the development of nurses as a role. This is not a regular document. It's sort of a framework for professional development. Level 5, the junior bachelor's, the basic professional role. Then level 6, bachelor's of nursing. They have more self-reliance within their competencies. And finally, medical nurse in a community of advanced practice, which is the master's in nursing. So a wider function, responsibilities. And then I'm urging, if you're not familiar with the document, please get in touch with it. So when I mentioned that most part of screening community can be conducted by nurses, if we are mentioning about the master's program in nursing, then the level of functioning and amount of responsibilities and functions you can compare. And I think that this does cover 2 words about the workforce. Workforce potential for nursing is being provided by 97 educational facilities. More than 7,000 nurses is being graduating from the medical educational facilities. So we are living in the big work shift and workforce drift and workforce deficit. And Roman Kolesnik has the data that 50-something% is the workforce deficit. I had the data that we have 30%, but no matter which number you pick, the answer is, can the educational system can actually prepare somebody for yesterday and not thinking about tomorrow? I mean, it's really rhetoric, and then and then the answer is no, we can't really. So I can't really say that it's all that bad was the education. So maybe my professional opinion cannot deviate myself to that. But what I want to mention additionally, to speak more so what is the biting factor for us, or what is holding us back in terms of education. First and foremost, it historically happened. This is not the criticism for a separate facility or a separate person. So it happened that the medical colleges, the only doctors are teaching to nurses. My personal opinion that the doctors, I'm also not a nurse. I am teaching to nurses. I am a doctor. And so I've been in Israel with the colleagues, and we were talking to each other, and then also a director of medical nursing school. And so she was really fascinated and saying, oh, we can just leave to the doctor only histology, anatomy, and basic subjects, because only practicing nurses are teaching their courses. Nothing against even though I do, the doctors that are teaching to nurses, but in practice, it's sort of outside of the real practice or the routine nursing aspects. And then on the training programs and working programs within the academic excellence, so we were developing ourselves. So we do have the right to develop ourselves, approve ourselves in medical colleges and institutions. So they're usually outside of the practice from what we've seen so far in our colleagues. And then here the answer to my first question, whether nurses want to take the responsibility upon themselves and what to do for them to want to have this responsibility. It's clear to develop the skills for leadership, to develop the skills for decision-making, responsibility-taking, and this has to be from the student years. And I guess this has to start from you have to, everybody stood up when the teacher is coming. If somebody didn't come, this is sort of like the tolerating the, and I guess the education of a leader is something different than what we're giving children now. And also a big issue the teacher with the innovative thinking, the teachers that you're proud of, they're frequently are leaving the profession because the salary is really small. The teacher of the medical college is around 2 times less than the nurse's salary. So even though there are people with the mission, and so we are still holding on to them, and we are hoping that they will stay within the system. I would also like to once again bring this to your attention and to demonstrate that not everything is that bad, and we do have things to be proud of. This is on the slide. We have a working program that nurses were making. This program has been developed with the support of the past. We worked for a year, the working group, and so I'm proud that this program of the specialization for IPC department, this is the pioneering program on the level of the government, the level of Ukraine, and it's being implemented in our college, and so we have the 95 nurses or assistant to doctors to epidemiologists we have prepared in 2025 to 2026, and then we are spreading this program. We have one of Frankivsk College is also implementing this program, but as a profound implementation, because none of the specialization, the Odessa College went through that, Dnipro College went through that. And as the last thing that I wanted to mention is if we are hoping and we want to see nurses and they're who are capable as the pushers for the community screening, we need to give them more autonomy. Then regarding education, the changes, the teacher is changing, then the whole generation changes, and investment in teaching, this is the investment in health, at least in the context of screening and the community levels. Thank you so much. And we are saying thank you to you, more applause to you. And so thank you for your presentation. This is an important reminder because of the people, and therefore I would like to say thank you to all the nurses in Ukraine. Thank you so much. A few interesting moments in offline and to other parts, and then you put up your phones. Today's, you can scan the QR code that will happen to be on the screen. The answer is yes or no. Is it sufficient to just do screening to improve the results? You can scan the QR code. Is this enough to just do the screening to improve the results? Yes or no?
Ми це вже далеко не вперше сьогодні робимо.
This is not the first time that we're doing. This is time number 4. So,
хоча бачу, що телефончики ще
and even though the phones are still being lifted up to scan this,
10 секунд.
10 seconds.
Фантазія. То завтра. Церемонія нагородження завтра.
The award ceremony is tomorrow.
Не переживайте.
Don't worry.
Але зараз ви собі пару балів заробили.
But you can earn a few points.
Так, ну що, з цим питанням розібралися.
You've gathered this question, but it's such a nice thing that the second question is right away. We have a question 4 to question 5. This is new QR code. You can have it, and the answer is the same, yes or no. Does trust to the system influence to the readiness to go for testing or screening? Does the trust to the system influence the readiness to go for
П'яте
testing.
питання нашої
Question number 5
швидкої
are our big
відповіді.
today quiz.
Так, на екранчиках щось не те, да, ви бачите?
There's something wrong on the screen, right?
Да. Спробуйте зісканувати ще разок, та, тому що бачу, що у когось вийшло, у когось не вийшло чомусь. Ні-ні, все має вийти, да, спробуйте, це інше питання.
This is another
Можливо.
question you can try.
Перезакрийте. Так от. Якраз під п'яте питання нам відбій.
And under question 5, we have finally the error word is over.
Так, ну що, бачу, що виходить потрошку, так? Давайте ще 10 секундочок.
So 10 more seconds and
5,
5, 4, 3, 2, 1.
Розібралися. Так, окей. Це було п'яте запитання, їх буде більше.
And then there's going to be more of them. There's going to be more questions tomorrow. And the award ceremony is tomorrow, so that there is no question to ask. And so we remember everything, and everyone, we are tracking it. It's all reported, and everybody will get their gifts. And we are getting to the next part of the day, and it will be really, really interesting because we will be able to hear the voices from communities, the experience from community. This will be a session of approaches and everything else. So we will hear the voices of people who are working with those challenges daily and are looking for solutions in practice. So we will ask for our speakers to talk in a more practical way. What didn't work, what helped, what kind of pieces of advice they could have given to the colleagues. And this is going to be a big session, many speakers, and then everybody would be able to hear their experience of them. So I guess the first to the floor is Andrei Bogdan, the city head of Horodny.
Доброго дня всім. Всіх
Good
вітаю.
afternoon to everybody. My warmest greetings to all of you. This is my pleasure to be here and speaking on behalf of my community and also as a member of this project. And here in the screen, you can see where our community is located, which is unique. It's unique for the entire Ukraine because we are bordering with two enemies, Belarus and Russia. So we are very close to the border. We have a lot of space. We have only 15 people per square kilometer in terms of population density and only one town. And here you can see the numbers reflecting the rural and urban population, which makes accessibility of our capital town quite challenged. There are some roads which do not have any tarmac on top, which is another complication in terms of transportation, on top of other challenges, because we are constantly experiencing shelling, very intensive shelling, particularly the recent 4 days, both Prigorodnya and the nearby villages. Some of them have been deserted because it's impossible to live and even survive being that close to the border. So again, there are some villages located as far as 38 kilometers away from the central town, which means that running your business is a challenge. Getting public transportation bus is also a challenge. As the result, we have to provide for independent logistics, making sure that the center of our community is accessible to any villager in the neighborhood. And again, this is not an advantage. This is a burden for us and problem and inconvenience for the people. Speaking of healthcare, it's represented both by the primary and secondary care. In primary care, we have health units which are sustained relying on our assets. And also, additionally to those health units, we have primary care stations located in community centers and in felter obstetric care units. And this is the central hospital, which accommodates both primary care and secondary care services. And again, as part of this transformation in the health sector reform, we didn't have enough family clinicians, and we were asking the GPs and pediatric care specialists also to take over this responsibility and to serve as primary care providers. And it worked well. Currently, about 80% of the patients, they have signed declarations with the family care providers in our territory. But now they are fighting for the patients. We know how it works. Speaking of equipment, it has everything needed, thanks to the special program of support from the regional government. And we also invited quite a big number of clinicians to serve here. We never had plenty of them. But speaking of the functions to be sustained, in our case scenario, in such a challenging logistically and territorially setting, we still are managing to provide service both to civilian as well as servicemen. Speaking of our partnership with PATH, first of all, we were occupied for 40 days. Well, this was not full-scale occupation, this was rather isolation. So no supplies were possible, including medicines, food supplies, fuel. And again, we were protesting in front of Russian servicemen who were blocking our supply convoys. And again, we wanted to establish alternative supply routes, but all of our attempts failed. Finally, when this isolation and occupation was over, we were deoccupied, and we were selected as one of the pioneers to join this initiative. When I first heard about screening, well, my impression was that definitely this would be something helpful, but I could not understand why it applies to my case scenario, because we have our central clinic with primary and secondary care providers. So later on, I was educated well enough to understand the importance of expanding the service portfolio, but how to make it, and how to make it relevant, and how to make it attractive for us, for the people, for the community, we had to make some difficult decisions. We had to find the people who would be doing this in the right way. But again, at that time, I started thinking, if you are pulling this cart, somebody will be kind enough to put extra weight on top of your cart. So definitely, having some assets like a library, which is not just a place to collect some books, this is also a community center in terms of culture, community actions, English language courses. There is also a gym at the same building. A small one, but it's available for adults and for the children. There is a daycare facility also, where children can stay for a couple of hours under supervision. So indeed, there were some options to make this library attractive, and an additional attraction could be used for the benefit of the screening site. And then it just kept on going. Once you start the ball keeps rolling. So again, we invited people. They were taking some books to read, remembering this is a library. There are some other public events were conducted. As you can see, the camouflage nets were manufactured in this very community center, and that's how it kept on working. Moreover, remembering this as a library, But this is the central unit. But we have a library cluster. There are other library units in local villages. Instead of cutting down on that infrastructure, we sustained it. We provided them with additional publications, including the health-related literature, trying to educate local people, because most of them refuse to go to a hospital up until the time when it really hurts. So definitely that is something to address. That is part of our culture and nature. Instead of going to a doctor, they would go to a neighbor, to a friend, seeking their advice about a pill they take or about something which helped them to get cured, because they heard of a story when their neighbor or a friend recovered from a disease taking some magic potion. So again, such social media indeed was important. And another important factor is to help those who do not have friends, relatives that they can rely on, such as elderly people. We have such a big number of people on retirement, because once you settle down in your senior age, after living such an active life, you definitely get isolated. Thankfully, we have a social service center with a very active director of the service who keeps them running. And we decided to engage them in our common activity with the screening center. And the social workers who live and work in those local villages, they also share awareness raising activities. They also share some publications. They help in taking blood pressure. The more so that everybody knows the local postman, the local librarian, the local social worker. So bringing them all together really produced a cumulative effect. And speaking of our approach, well, let me start with the challenge first of all. And the challenge was that people don't come for screening. They experience difficulties with travel. Yes, this is challenging, as I explained this earlier, especially at the time when you need it, because you have to catch the bus. You have to make sure that you stand in line to get to the doctor on the day when you come. And sometimes such screening and diagnostic, well, of course, it was available earlier, but implementation of this program and this project supported by PATH, it incentivized us to do some broader action, and some active approach definitely produced a result. And result is obvious. I mean, this is not just the number of people who got screened and tested, but also the fact that they started paying attention to that. They started discussing it. And it really started functioning the way it should. Even if this project stops, we are not going to stop. We will continue doing the same action and making sure that other agencies are also involved in this common activity. So indeed, this was organized in a wonderful manner. Originally, I was rather skeptic, but after attending a webinar, it was actually a workshop for 2 full days, so I learned better about it, and indeed I realized how important this could be. And today we had wonderful meeting as well. So now we are partnering with some cross-border partners, like from Tatar Bonari, for example. And again, such experience sharing activities were also helpful. We have not just exchanged our experience and contact phones, but also we established other partnership programs, because there are different ways to cooperate. Hospitals with hospitals, communities with communities in other sectors. So indeed, these were wonderful opportunities, including those offline events which were facilitated helping us to get some release from that burden and routine that we are surviving. And speaking of the numbers again, more than 10,000 screening sessions were performed, and the results were really outstanding. Definitely, sometimes it was difficult to get all of them to the doctors as they should, but all of the girls and boys who were invited to such screenings, all of them were connected to their family clinicians, and all of their health issues were identified, and this data was shared with the clinicians along with their contact phone numbers, so that the clinicians would be paying attention to having such cases and such patients, getting in touch with them to follow up. And indeed, as the result, this entire technology changed and improved. And here, please make a copy of our contacts. And on that note, let me thank all of you and all of us once again, because this is the right job we're doing. This is the good job we are doing. Now I'm deeply convinced in that. And we definitely will continue this screening initiative for the benefit of our people. And I do strongly believe that our people enjoy this as well, because now they can see that somebody cares. They don't any longer complain that everybody has forgotten about them, like I witnessed earlier, because indeed, doing the field missions to the remote villages earlier, I heard those complaints that people believe they are abandoned, they are forgotten. So instead, we have to make sure we remind them about the fact that we do care. Thank you, dear Andrei. And I believe this is not everything that you brought for our meeting. As a matter of fact, yes. I would like to use this wonderful opportunity for the sake of sharing a very special prize with the project managers, Gonta, and other partners. This is the ceremonial bread that was produced by our villagers. So here's from the northernmost point of our Ukraine with all heartfelt. So with the heartfelt words of appreciation, our goes to Gonta Gravnitsa for her care and passion in supporting Grodnyanska Gramada in the most challenging times of the project implementation. This was made by our children, and I believe you recognize where Gorodyanka is. And again, thank you so much. And we are looking forward to have you as guests again. Currently, this might be a bit dangerous, but being in Ukraine is dangerous in any place. But our community is quite special. We learned a lot, but we're happy to share and help you learn even more. Thank you so much. This is exceptionally pleasant endeavor. And please forward all of these words of appreciation and applause back to your villagers in your Gramada. And with that, happy to invite another speaker to the stage, Irina Kauza, the acting director of the Primary Healthcare Center from Gorokhiv town. Good afternoon, my dear colleagues. Let me present our report to your attention. I'm representing the Gorokhiv PHC, and we also would like to share our experience of taking health services closer to our community via use of a mobile X-ray unit with artificial intelligence. And here we understand how important this is to manage the distances for the patients to come to the services, but also to reduce that detection on the distance by means of taking the service closer to people with disability, with impaired mobility, to displaced people. And as the result, Earlier, our system was waiting for people to come, and a very big portion of people never came to seek healthcare because of different challenges. As a result, we had late detection of TB and other respiratory tract diseases, low coverage with screening, and passive case finding primarily. Thus, the major challenge was in the fact that the system existed, but many users and customers could not enjoy having the service rendered by that system because of different challenges. And thus, our main approach, speaking from a philosophical point of view, which was making sure the system starts moving towards the people, not vice versa. No longer we wait for patients to come. Instead, we are taking the services closer to the places where people live, actively engaging with the communities, and offering our service at the earliest stage possible before they fell ill and require treatment. Explaining how it works in practice, this does not engage patients in travel. They don't have to make an appointment or face any challenges in terms of logistics. Instead, we have a monthly travel schedule covering different villages, boarding schools, community centers for IDPs. We bring our portable X-ray machine to the respective locations in those settlements, and all of the images are scanned by the artificial intelligence technology, which later on is validated by the X-ray specialist. This can be done remotely or personally. And then the scanning results go to information system immediately for further use. But again, artificial intelligence is not a replacement for a clinician. This is an aid provider to a clinician, highlighting some pathology, prioritizing some of those concerns, and respectively focusing their attention on such results. And then clinician, relying on their experience and training, they can better utilize their skills and competencies here. Speaking of the results, we made 32 field missions to different communities, and cumulatively, including outpatients and inpatients, we made 3,076 X-ray images, having identified 516 pathologies. Looking at those numbers and comparing them, here we have compared, and thus the case finding rate was 21.9% during the field missions versus 15.2% in the inpatient settings.
And the ones that we're going to, we are testing patients more so burdened with diseases and advanced stage population that are finding it hard to get there or get to the health facilities with mobility issues. Among the IDPs that have mobility issues and don't have a contact with a doctor, and you see in the numbers, we have much higher level of detection during the visits than through a regular in-hospital detection rate. So what did we brought up out of this experience? The experience sets the results. If the person can't get to the service, they're not a part of the system. So we are not seeing that person. And removing the access barriers, the first and the most important thing. The moving out is not an option. This is the only way to cover ones who can't physically get to you themselves. This is not an additional service. This is the main model, and this is the main grounds for the model. And there's two different audiences. People during those visits, they're much more vulnerable. They want to have more attention. They're more isolated from, they feel like they're more isolated from everywhere else. And also the mobile X-ray, they're working when there's a specific pathway, so that itself, the equipment is not working only when there are people that are working with it and when there's a specific pathway that you're trying to follow.
primary care is coordinating, referring, and providing the continuity of care for every patient during the visits for treatment. What has changed for the inhabitants of community diagnostic services became accessible. You don't need to conquer a long way. You don't have to wait for months for and a bigger readiness for medical examination, and also an increase of trust to the primary care, and also early detection of diseases, which is the bigger chances for getting better and for timely detection. And so for the vulnerable groups of population, and for many advanced stage population, people with decreased mobility, people with the internally displaced people status, this was the first experience, their first initial experience of going for X-ray at the place of residence and not somewhere else. And the program has not just increased the access, but for many population, they created the access where they didn't have it before. Mobile diagnostics reaches out people where you can't, where the inpatient can really get to. The artificial intelligence open up the ability for the doctors and also in the X-ray system, and family doctors can also see that there is the process by scanned by an AI coordinator of a pathways, the family doctor, and the primary care center. From January of 2026, we are working together with the organization Red Cross in our region that are providing with us for the transportation fuel. We have created a mobile multidisciplinary team from the multi-profile hospital that are providing us with the X-ray assistant, then the remotely involved X-ray doctor, and then the teams goes to the village for the improvement of diagnostics and timely detection of conditions, diseases, and for people as well. If you are to summarize with one sentence for us, the main conclusion is that early detection starts not in the hospital. Early detection starts there where people are staying. Mobile diagnostics allows us to get to ones that the inpatient system cannot get to. Artificial intelligence helps us to spread the ability that the doctor has, where the workforce restrictions are present in the primary care center, as well as always the main coordinator, pathfinder for the patient, and always saying that the family doctor is a friend to a patient, and they always want to help people as much as possible. Thank you so much. Thank you so much for your story, for sharing, for all your community and your colleagues. Thank you so much. And so we're moving on. I'd like to welcome Dmitro, the head of the Department of Family Social Protection and Health of Решетилля City Council. Greetings, dear colleagues. My name is Dmitro, and I wanted to visualize where the Решетилivka city is located. It's in Poltava district, in the very center, 300 kilometers to Kyiv, 160 to Kharkiv, and 30 kilometers to Poltava city. From the very beginning of the full-scale invasion, our region has become a buffer, and our community made more than 4,000 internally displaced people, which is a lot. And so right now, as of today, we have 1,200 internally displaced people, more than 26,000 population of our community. All of the community has the overall surface area 140 square kilometers. It has 85 settlements, among which one village in Решетилivka city, which is a lot. We've organized one of the things that we face an issue that there's a lot of population. To Решетилivka city, there are villages that are for longer than 20 kilometers, so they're just stretched on the map. And so this is why we wanted to cover all of the population to make them accessible services, and especially screening services. And so our 14 settlements, that if you were to separate our community, they are all located in the rural or faraway areas, and therefore the inhabitants of faraway areas, they're not forgotten, and everybody remembers about them, and they see this all because of our actions and our efforts. From the 15th of April 2024, we've started the participate in the program, and from that moment, and throughout 2025, 7,000 people have went through screening. The screening itself had happened in the ambulatories of general practice of family medicine, Felcher, Obstetrician Point, House Point, and also in one of their settlements in the school. On the first floor, they have the accessibility, and then inclusivity aspects are covered, so like you can get there in a wheelchair. Anyhow, the main thing that was mentioned by Andrzej Bohdan before, and when people are coming to the city head or anybody responsible for health, but they're saying, but this is medical, let's medics do that, but not really. The participation and the role from the head of the community in such a meeting and trainings and everything else is really important, because they, with their own eyes and ears and their own fingers essentially, are touching this issue. They can feel it, they're going through this issue is coming through them, and so they're listening to everybody who is telling them. Our city head, Oksana Dizunova, was the assistance of the project, and for the funds of the Shtile community, we've reached to the fact that our community don't have a mammography equipment. We bought it. We've spent not a lot of 10 million hryvnias for the community. This is not a lot of funds, because as it was mentioned by the Roman, every hryvnia invested in prevention, this is the cheaper than every hryvnia invested in treatment. So we need to understand this. And then from the beginning, when we bought a mammography equipment, is that when the doctor went through training, and from November to the 31st of December, we were able to detect 12 cases. In 12 cases, this is a lot, but almost everybody went to get the screening, because everybody heard that our community has a mammography. The closest one was in Poltava. So the waiting list is for more than 500 people, and there's nothing to do about this. And the next part, which is 100 kilometers in Lubny city, this the same situation. So what will we be able to do and know and get from there? And our city head and the promotion of the healthy lifestyle is also going there. So we all know that the full role of the community in provision of healthy community, not just for treatment, but the healthy community to exist. The moment of the spreading in the widening the diagnostics, you can see that people are coming to get tested, and educated personnel that knows and explains and directs the future oncological facilities of the region or throughout the country that can help those people get tested, treated, and all that. This is all free of charge by the e-prescription. For 2025, we were able to see testing done, how many cardiovascular condition, how many diabetes mellitus, and other types of screening has done. And together with that, we would want to mention that in reality, the bigger percentage of people who went for screening and actually got to the doctor to get the result of their diagnosis, most of them are women. Men have a low level of health literacy. If you could take like a regular guy named Petro from Meshitilka, you say that you have these indicators, you can need to go to a doctor. He will get a cigarette, will start smoking, saying it's nothing, it hurts me, just don't touch me. So we need to take this from the smallest of age to teach children the medical literacy and health literacy. We need to push children to understand, because the younger generation, if to the Soviet generation, or the ones who were born in the 90s in Ukraine. It's really hard to reach them. Then we need to teach the youngest so that they would approve this and would take this whole initiative and would provide for us the healthy future generation, because we really need them to be present there. What's concerning mental health? As you probably know, that any era where it's going to end, but the anxiety inside of yourself might never finish. And so that the person might be bringing this burden throughout his life in the future. And if somebody is not going to be paying attention to them, not going to propose like any kind of assistance, help, or support, then we will have a generation is going to be sick in our community. For internally displaced people and for veterans of war, we are organizing groups, the self-care groups, and then, but we still need to think about the local population that is riddled with anxiety, don't know where to go, move, or anything else. And this is why it's so important, as Andrei Bogdan, to have the self-development clubs, even the biggest level, to select a public figure so that he would go outside and would conduct a minimal physical exercise 3 times a week would be a great thing for any community. There's nothing hard, complex, and would take no extra funds for that, essentially. The Shtila community is really grateful to the project, really grateful to all the team of the project. Once again, the role of the head of the community is important in training. It's really important. And it's also important after the whole process was started, and then the head of the community has to live through all of that because of them. It's supposed to go through. My personal experience since health and social protection, as I mentioned before, how was it being merged? And I'll tell you all about this tomorrow. But this is it from my side. All of the stages, from the first contact to the diagnosis to the treatment, we've all heard it, how this is moving on. And let me repeat myself. So the men are supposed to be attentive to their health, because I think that tomorrow Timur will change, and then they will go to screening. Thank you so much. You're not leaving me any chances to not get better. Thank you, Dmitro. Thank you, everybody. And so, another presentation, and that was a fantastic speaker. I'd just like to welcome Stanislav Chorny, the director of Pavliv Primary Healthcare Center. Greetings, dear colleagues. After such an emotional presentations, I'm not going to be a star, but to close this session, but I'll do my best. My presentation doesn't have a map, but I understood that this is a loss on my side. The north of Odessa, 200 kilometers to Odessa, 300 kilometers to Kiev, and say that we are near Kiev, essentially. In the north of Odessa, this is our reality. The primary care center serves for 2 communities, more than 30,000 inhabitants, and now the number of people has decreased who moved out, who have died, and so unfortunately we have 28,000 contracts for primary healthcare services provision. I can say in this call, everybody's original, everybody's special, and sharing the experience. This is not really, I guess, a thing that you're getting the pleasure from, because we all have our own infrastructure, we have our own capacity, we have our own personnel. Somebody has, somebody doesn't. We have our own rooms that are better and more or less adapted. This is why I'm not urging you to be like us, but I'm always saying you can always see and read about us in the social media. So I'm grateful for, in 2016, we have created primary care centers in the health department, and then And when I started to work in a primary care center, some of the pictures from our center you probably seen, I was even fascinated myself as people, and I even saw myself. This is where I'm thankful to the project about such a PR. We're glad we have a picture that I've been here. I'm almost been in Forbes. It's not Forbes, but it's a really close in nature and spirit. The primary care center, by grateful to the project and whoever involved for us getting there. Our primary care center started to be included in the screening in 2024. And almost for all the 2025, and for us, it was positive in terms of we were able to practically do a lot of research, a lot of tests. This is more than 6,000 tests were conducted and carried out by us, and I would like to say that we covered 25 screening points. It's a positive. And we also opened it in 20 villages, so we preserved the buildings. So there's Natalia been present here, and Yevhen, who's also been there. So I would like to hear that before this time, for months time, we are. It's an interesting idea. We have we will have medical nurses of community. So maybe it's going to be a great experience, but I would say that then it's supposed to be funded from other budgets. But without those centers that are for health in villages, and we have more than 20, we wouldn't be able to do anything. Even though by starting from the order number 504, the screening was a new thing for us. I'm grateful to the project because from one side, this was something new, something they filled us, and I'm hopeful that those words are not going to be assessed wrongly, but 1,300,000 hryvnia, this is something we was the project and the screening for 18 on top of that was the equipment, expendables, and other things. And this was also my personal wish because this has reduced the load. In our budget from the second side, we had our eyes, our hands, our legs, and the villages where you can do the screening and implement the screening. And from this third side, the project didn't allow us, because of Helena and others who worked in that area worked, it didn't allow us to, and every day they calculate what is happening, what is new. So if there's no control, there's no work. So I'm grateful to you and to the project that you did this for us. I would like to take part from the screening 18 and over, go to screening 40 on top. It's not the same issues, not the issues about the fund that will open after tomorrow and the funds will go forward. Now have the a lot of people that I will be doing screening for, not about 2 months, that will be taking. Because in May, when we were saying that the ministers' meeting, I said that please propose what we can give to the patient. Somebody thinks that in my pocket, 2,000 hryvnias are burdening me, and I think how to bring this to the primary care center. It's not going to be true. The healthy way and an open day, this is something that can give a push, because 2,000 hryvnias my birthday has went through, and I already given my fund the same, my center, so I've supported myself materially. And so there are moments in terms of 40 and over when in a meeting the city had, or he said, tell us about the screening, and then the question, what will people do in villages? 40 and over, it's not going to get, the banks are not going, cards are not being opened, the grandmas, you can't get to the bank to make a picture, the employee of the bank is not going to go there. Not every grandma has an iPhone, and not every grandma knows how to work with it. It has 4 areas of work, who is going where, and so that from the moment I want to have a screening 40 over to the moment, here's my money, please test me.
Once again, the complex problems are persistent. And in Odessa, we are probably one of the leaders in terms of gravity and magnitude of those problems. We are not even equal to smart labs who can take patients by hundreds. Nevertheless, we are fully confident that the Screening Plus initiatives is the answer to many questions from the people. And in case something is not working right, I'm using the option 18 plus as the solution. That was my message at the mayor's meeting. This is my message here, because we have capacity, we have people, we have laboratories and equipment, and please use that. Speaking of some failures, we do have those as well. And again, there are some units which are not part of medical infrastructure. We also have a wonderful library. We're hosting different events and international visitors. And we do have a screening unit there. It's small, but it's functional. Also, we have a center of administrative services, which is basically across the street from the primary care unit. And it's equally accessible. And there we have a room which was redesigned to accommodate a clinical office. And thanks to our community budget, we repaired it quite decently, so we definitely can host patients' visit there. So it's functional, and there were 2 inspections coming to see whether such centers are functional, and we managed to demonstrate such 2 units functioning. There was an option 3. There was a separate room in the administrative building. Well, there could be some area shielded in the corridor, but that was not deemed appropriate. So instead, we started using mobile units. We are taking those mobile units to local schools, to vocational schools, to teacher training college. And thus, we have the mobile unit with the equipment and personnel doing the same in the field environment. So again, this is unrolling, and once screening is prescribed by the Order 504, but instead of limiting this to 40 plus only, it has to be expanded to include everybody as part of 18 plus category. And that definitely will show some results. And we can see the results of TB cases found thanks to such screening. But most importantly, we can see that this is inducing some patients thinking about their health. And we also are empowering the nurses, at least to see what kind of greater role they can play, to see only, maybe not execute it fully at this moment, because sometimes when the nurse can see something, obviously in the patient case scenario, but again, there are some confidentiality issues which have to be observed. And again, this is a very helpful idea when a nurse will be forwarding this case to clinical attention, but it has to be well designed. In any case, results of the screening on having 6,000 screenings, examinations, whatever you call it. But again, speaking of the bridges over that gap you were discussing earlier, some of them have not been erected yet. And here, I'd like to suggest a solution which would be informational campaigns. On the one hand, it was clear why we were selected for this project, because some of the indicators for the city were declining. And again, urban territory is different from rural, and people living in towns, maybe they have different attitude, but when you're talking to a villager, they do have a lot of confidence in local nurses and clinicians. While everybody living in a city, they do know that clinic is right here, next door. If it hurts real bad, then only they will go and seek help. So there could be different informational campaigns that would be triggering respective behavioral changes in different type of residents, rural versus urban. And sometimes they are not just conscious about the importance of paying attention to those small indications of ill health or the right time when to care about their health. And the results of such campaign, and again, probably you remember at the time when you started this project, we have quite a big municipality. I believe we were pioneers of establishing a local council back in 2016 with a full communication unit as part of that. We have our TV channel, we have lots of publicity shared in media. And this was important enough to have some communication officers in the local community to be engaged. And I'm quite thankful for this selection and for the results. But describing some of those communication products that were used in order to better understand how this works and what could be the difficulties. The fact is that our clients where to go. They heard about this initiative, they really saw the results of this project, and there were funds invested to procure everything necessary for visibility. I mean, the banner, the bracelets, the air balloons, the blood sugar meters, to make sure they are available. Sometimes we had difficulties in finding a right location or getting the right weather to bring people along. And also, there was a special event at the Christmas fair. And just imagine, some people are buying ham and sausages for Christmas, and next to that we have a banner about good health and healthy diet. So again, this is something to bear in mind. And I'm quite thankful to the local CDC and everybody who supported us from the Oblast Center, and also our communication manager and coordinator, dear Tatiana, this is to you, as well as leadership of our CDC, because they shared the immunization bus to travel around the city and screen 87 people. This was important in the middle of December. Just imagine taking your blood, sugar, and everything else out in the street in the middle of December. So this was healthy aid. And again, our central clinic was nearby. This was also important. So again, if you rely on such mobile solution, that would be one case scenario. But instead, why not do this in comfortable environment any time of the day, any day of the week, from Monday through Friday, where it's warm and cozy. And again, sorry for this confused narration, but here again, coming back to communication, these are the channels we used and the messages that were delivered via shared approach in media, on professionals. All of that resulted in cumulative increase of the number of patients, which definitely indicates the change in the consciousness and understanding of our people. Of course, we faced some barriers. We identified some of them. They are listed here, so bear them in mind in your awareness-raising campaign. And also, it was a pleasure to me to see my peers coming here to the stage, thanking the project, thanking Gunta, and speaking on my personal behalf and on behalf of our community. We did exactly the same 2 or maybe 3 days. I hope this expression of appreciation came to you, Gunta. But taking this forward, and frankly speaking, I'm a bit confused among these slides because I saw the final version only today in the morning. So again, one of the opening slides was describing how different we are. But again, we have so many things in common. And if the government wants to support the health in communities, they should be starting to do that in small matters. And we want to make sure that everything it takes in terms of screening as a comprehensive intervention will be done in full complexity, including PSA testing, which was removed from the testing panel, will be brought back in order to make sure that we can test people thoroughly. And here we have the deputy director, and we are cooperating quite closely. And again, I'm surprised on the one hand, and I'm happy on account of the people from Poltava with their idea regarding the mammography, because we have a similar idea. And Roman Rodina suggested that if you have problems with the stationary mammographer, and then you have only one mobile mammographer processing only 20 tests with very low coverage. So definitely this will not be a solution. So, and again, this is inducing us to look for other solutions. And I'm thankful to the mayor, to the governor, to the social service chair, and many other stars that were falling into the right constellation. And now we'll be happy to enjoy having a mammographer soon enough. I had a picture, but again, it's been installed. There is some piece, nuts or bolts missing. But most importantly, we will have access to mammography soon enough. And I was very carefully listening to Madam Natalia's presentation regarding the indicators, which are suggesting that sometimes referral is delayed. But speaking of the referral rate, again, I was hoping to discuss this with Madam Natalia, and looking at our situation and comparing it with other people's indicators, we're quite reasonably high in the chart. But yet this is only one more time reminding us how important this is to go and check it. And PSA was missing in my testing panel, so I had to do it additionally, and thus inducing me to move forward. And once you keep pushing forward, you will have the result. And now, looking at my watch, I do understand that I'm behind my time, but since nobody is knocking me out of this stage, let me describe something else we did last Friday. And again, thanks to the project, this is another action which is the product of this project. And this is about mental health. This is a resilience center with two-storied building and a basement with a separate entrance and a separate office which looks decent enough for children to be allowed to come and play. And there you can see the counseling room for psychologists. And we had some gatherings with volunteers and servicemen, with the psychologist who was organizing that. I mean the group works, group exercise with our personnel, and more than 100 people of our staff came to such sessions. And here you can see some snapshots of other amenities and utilities we have to be dedicated to support of our veterans and of our staff. And I'm happy that Madam Zaika paid so much attention to prevention of burnout effect, because indeed we have to care for the patients, but we have to care for the carers, because otherwise you will have no staff to care for the patients. So with that, I finish my presentation and apologize for delay with my timing. Thank you so much to your story, thank you to your community, and thank you for being with us. And with that, dear ladies and gentlemen, let me invite all of you to a round of applause to congratulate all of the communities and all of the speakers in our agenda today. But we have another surprise for you. It will take another couple of minutes to get the stage set. I don't want to anticipate and disclose any secrets. You will see all of that in a couple of minutes, unless somebody knows about that little something. So while people are working here at the stage, do pay attention to the cards which you have in your seats. There you have a green yes as a tick and red no as a cross, respectively. So I will have some answers for you and invite you to answer with either green tick yes or red cross no. And my first question is as follows. Was there any moment during the day today when you thought, yes, this is my story? Okay, I can see 2 red marks. Only 2 red marks. So there was not a single story that was close to your case scenario, right? Please explain what makes you different. Dear Gonta, how come? Yes, everything was quite new and everything is quite well. So you have the excellent case scenario situation. Okay, in that case, what were the absolute highlights?
Того, що опустили.
And why are your eyes looking at the floor instead of the sky high?
Да, ми пропустили, повернулися. Чи був момент, да, сьогодні,
So
коли
again,
щось
the question
на
is
сцені
about a
відбувалося,
moment in time here at the stage, one of the stories told when you thought this is your lifetime story. So this was your case scenario. Please explain what that story was about. Please explain. This was about the referral 40 plus service which I failed to use. As a matter of fact, the something that I just did, I went to the Dia app and it's frozen. And now I had to go to the stage. So I'm working on it. I will announce the surprise, which will be the next part of our agenda, and I will make that happen. Okay, next question. Speaking of your community, does it ever happen that a patient disappears after the screening? And you said no.
У вас такого нема.
Not in your case scenario, right?
Розкажіть, як ви до
Never disappearing.
Розкажіть.
Okay, can you explain how you manage that? They never disappear. We invite them to visit in our outpatient care setting. If there are any issues found, we are managing them immediately, referring and controlling. How is it possible? How are you controlling? Do they tie or cuff their hands?
Так, я ще бачу
Okay,
когось
no
від
secrets revealed.
у кого вона була.
Again, somebody else suggested no, they are not disappearing. No more disappearance. Okay.
Так, наступне запитання. Чи
Next
буває,
question
що ми
then.
більше говоримо
Does it
про
ever happen that we are talking about integration more than actually doing that reintegration?
піднімають відповіді, замислилися.
Somehow you are thoughtful. There is no immediate answer you are producing. But yet we have so many green ticks. Thank you for being honest. Thank you for being brave. Thank you for making conclusions and changing the situation for the better. Have you heard today any idea that you would like to try after this conference?
Так, хто ви не почули жодної такої ідеї, да?
You haven't heard any new idea?
Хрестик, да?
Is that why you have the Red Cross?
Ні, не у вас, да? Прям взагалі не здивував.
Not in your case scenario. Nobody surprised.
А чим
No
взагалі
innovations.
здивувати?
Is there anything on this globe that can surprise you?
Я думаю, що те, що
Nothing and never. Well, what's going to happen next on the stage will be surprising you, definitely. I will come back to you. And you are the only one who is holding the tick. Please share. Well, this Kahoot quiz, I enjoyed it greatly. So I made a tick in my diary because I'm the librarian. And I was so enthusiastic to provide the responses. And I was guessing some of the responses because I didn't know answer to some questions, but I could guess about that. And again, Orodnya was victorious in this quiz, so I will definitely run that game with my clients. And again, this is a very good interactive. Yes, indeed, this is gamification of different issues when you are delivering important messages in a playful manner. And Kahoot does ignite people and children too. Yes, indeed. Very nice.
Засвоюється різноманітна інформація. Клас, дякую. Завтра ще зробимо Kahoot. Добре?
We'll make another Kahoot tomorrow. And thank you so much.
Так. Чи можна покращити
Can we
результати
improve the
скринінgu
results of
без зміни
screening
побутів
without a
і
change in the behavior of human beings?
Та, є одна зелена галочка.
There's one
Чи
green
ви просто перепутали?
bar, but or you just
А я чекав.
misjudged
Ну,
it, and I was
були
waiting
галочки?
that there's gonna be
Ні,
somebody or
одностайно,
not,
одностайно.
and it was
Всі
the unanimous.
сказали, що
Everybody
будуть,
shown
хрестики.
the
Дякую вам,
the
за, це
red
розуміння,
crosses.
так?
Thank you for
Ну, я не буду
the
питати,
understanding, and
як
I'm not
ви
gonna be
робите
asking
таку
how
зброю, да? У вас же
you
нема,
would,
тих, хто
because you don't have the
рухається.
ones who are
От як
being
ви
left
змінюєте
behind. So
поведінку?
how are you
Чи
changing
я
the
запитав?
behavior?
От як ви впливаєте на ось цю
So how are you influencing this behavior? So we are trying to talk to them. The population is not that big. 1,200 people, minus children. If they're not coming to us, we are coming to them.
Все максимально зрозуміло і максимально
It's simple, clear,
дієво, так? І ефективно.
and
Клас, дякую.
effective.
Давайте
Thank you
ще
so
одне
much.
запитання.
And another
Можливо,
question.
трохи відпочити
Are you ready to rest a bit
від слайдів і подивитися, що
from
дійсно
slide and to watch
неочікуване?
something
О, і
unexpected?
отут, але
And
вже така
here,
потужна зелена. Так, то була червона
and I
одна
said
складність,
green bar, so
зелена
that was
одна
all
складність.
red, and now it's all
Супер.
green.
Ну,
So
тому
thank
я
you
так
so
розумію,
much.
що
And then I
абсолютно
think
все
that
готово.
everything is
Зараз
ready
наразі
right
після
now in
програми
our
буде
agenda.
такий
We're gonna have a
сюрприз,
big
особливий момент, я би
surprise,
сказав.
a special
Протягом дня ми
moment.
з вами дуже
Throughout the
багато
day, we
говорили про
have
громади
talked a lot
як
about
про
communities
простір
as a
рішень,
space
підтримки,
of
змін,
solutions,
але
decisions,
громада
changes, but the
це не
community
лише
is not just
інституції,
an
послуги,
institution,
маршрути.
services,
Це передусім
pathways.
люди.
This is first and
Люди,
foremost
їхня
people.
енергія,
People, their
їхній
energy,
голос,
their
пам'ять і
voices,
здатність
memories, and
бути
ability to
разом.
be
І зараз
together.
одна
And so
із
today,
громад
one of
підготувала
the
для нас
communities prepared for
справді
us
творчий
a real,
сюрприз.
a
Такий
creative
абсолютно
surprise. So
живий,
honest,
справжній,
live,
такий людський.
human-like. This is why it was a great pleasure. I'm passing the floor to them. Please welcome.
Музика – це вид мистецтва, що втілює емоції, ідеї та настрій.
Music is something that encompasses attention, ideas, and this is a way to self-express that influence a person emotionally, helps to detect joy and support in complex time. This is also a special form to add in feeling that it's impossible to just give with words. So we propose to your attention a musical welcome program in the continuation to such an important event in health by unifying every participant here around this song, your own language, and support to one another. And this is this hard time for us, for our country, for everybody. Thank you.
Милий серцю рідний край, де світе весни розмага, де спадають чисті роси на хлібів рясних полях. Милий серцю рідний край, мій вишневий зелен гай, де лунає день і вночі дивна пісня солов'я. Земле, матінко моя, я люблю твої поля, я люблю твої простори, ріки і високі гори, вірним серцем назавжди. Милий серцю рідний край, життєдальний коробак, іскряність твоїх глибоких, повниться жива вода. Милий серцю рідний край, ти цвіти і розквітай, край краса твоя, Україно, буде вічно молода. Земле, матінко моя, я люблю твої поля, я люблю твої простори, ріки і високі
Кожен з присутніх у цьому залі має безцінний життєвий досвід.
Everybody present here has a valuable life experience that has many things happening. This is why the music will welcome to your attention the Moments of Life music group that presents the Gorохівський community of Volyn region. This is the groups of people that has burned from the great will to have the live music being present in everybody's life as they participate in different events for a wide spectrum of visitors independently on your profession and status. So the founder and the participants of this group is the head of the Gorохівський community, Victor Godek, that had merged around him. The collective is his example by learning how to play the saxophone himself. So this initiative is the words of gratitude to all the people who are working tirelessly in developing our community, everybody at their own space. The creative pathway, this is the Victor Godek started with the following song that we will want for you to listen. The instrumental version of Ukrainian song "Чом ти не прийшов?" or "Why didn't you come?"
Музичне мистецтво – це сильний терапевтичний
Music as a culture, this is the strong medicine and remedy that everybody needs, especially now, to reduce stress, anxiety, stabilize yourself and recover, and also the strong instruments in supporting to getting back to your senses and improve your personal state of being. Please try to feel right now, everyone at you, it was the following melody.
Команда музичного гурту
The
складається
team
з
of
професійних
our
музикантів,
community has a professional musician of different level, bass guitar, teacher of music at school, and head of the community of Orkesco.
барабани, завідувач господарства
Drums,
центральної бібліотеки,
the head of the Central Library, Leonid Vityuk.
клавішні інструменти,
So,
директорка Народного дому
Piano,
просвіти
director
Марія
of Community Center Mia Latvia,
начальник відділу
and the head of the Department of Culture, Alexander Shipshalay.
інструментальні солісти,
The instruments for saxophone, Draholik,
та саксофон альт Богдан
and saxophone alt, Bogdan Shepshalay.
а також вокалістки
And also the
Вікторія
vocalist Victoria Fedina, Katerina Stebuk,
та Оксана Курілко.
and Oksana Kurilko.
У нашому житті були
In our lives, there've been and still are different people, colleagues, people that we know, close ones, friends and relatives, but this special place in our lives that cannot be replaced by anybody, which is our parents. In memory of them, which is the bowing for happy childhood, for mother's love and care.
Ніби вчора, рідна мамо, ви мене будили рано, промінь сонця зустрічали солов'ї. Пастухи череду гнали, на сопілках вигравали, горлицею торкотіли ви мені. Вже дарує сонечко новинам день, вже це не співаний іще пісень, щедроти черпни у ньому доброти, а у ранків золотистих чистоти. Ти от сили набирайся у землі, пам'ятай, що день слова мої.
сонечко новинам черенцями співами піше пісень, щедроти черпни у ньому доброти, а уранці золотистих чистоти, ти сили набирайся у землі, пам'ятай щодень слова мої.
Годинник відлічує час роками.
The watch is ticking down the time, year after year, changing the rhythm, but never setting your memories aside about the time of your youth and new horizons. And such warm memories, they always keep our heart warm, so may they flower in spring like flowers throughout your soul and lifetime.
На горі той зелен клен, немов чаклун він мені, дарує чари кожен день. І бере той зелен клен у полон, немов чаклун уночі. І в очі сон ворожило сонце у гаях, і тепер тополя я твоя. На горі трава зелена, я тополя біля клена, наречена зоряна його. На горі трава зелена, я тополя біля клена, наречена зоряна його. Батьку мій, даремно ти не гукай, така вже доля моя. Забула я своє ім'я. Дощі, то зелен клен на сматі, я вірю їх рушником, зустрінеш ти. Я дарую літу білий сніг, бо тепер тополя я повік. Погодивши сині очі, нам любов чарує очі, та чомусь у серце попада. Помоливши сині очі, нам любов чарує очі, та чомусь у серце попада. Я дарую літу білий сніг, бо тепер тополя я повік. Найщасливіші, найдивовижніші моменти
The happiest and the most miraculous time in your life is when you're meeting your second half. So may there be unrelentless depth of feeling to be shared among both of you.
На пероні, на люднім пероні, де не чути далекого стуку, хтось розсипав троянди червоні, і, здається, ніхто їх не бачить. А троянди до людей пелюстками кричать: ми не квіти, ми кохання, а кохання не можна топтать. В моїм серці чи білі, чи то смуток, не зустрів ти мене і сьогодні. Хтось дарує комусь поцілунок, а хтось топче троянди червоні. А троянди до людей пелюстками кричать: ми не квіти, ми кохання, а кохання не можна топтать. На пероні, на тихім пероні, вже не чути далекого стуку, хтось розсипав троянди червоні, чи то зустріч свою, чи розлуку. А троянди до людей пелюстками кричать: ми не квіти, ми кохання, а кохання не можна топтать. Ми не квіти, ми кохання, а кохання не можна топтать. А кохання не можна топтать.
Життя нашої країни, кожного
Life
з нас.
of our country and every one of us today is full of challenges
Сьогоднішні музичні вітання
and difficulties. So may these musical greetings serve as lucky charm to each and every one of us in these difficult times. And may you have the sweetest possible memories of this meeting today, making sure that everything will be fine in your life ever after.
Якщо ти марнуєш дні серед злиднів і брехні, і щасливий тільки у вісні, все навкруг немов тюрма, все покинула пітьма, і надії начебто нема. А свою країну захищай, і святої віри не втрачай у батьківський край. Прийде час, ще засяє сонце і для нас, ще вогонь у серці не погас,
присутнього у цій залі ніколи не перетиналися один з одним.
Our
Але дороги
pathways have never been crossing before, but the directions that we are moving into take us to better blessing and fate to all of the people. So may you be rewarded by peaceful deeds and accomplishments in peace and love.
Як так, що небо злітає, як річка в долині біжить, до вас хай добро завітає, і піснею в серці звучить. Щастя, добра і любові, щиро бажаємо вам. Щастя, добра і любові, дітям, онукам, батькам. Щастя, добра і любові, звучить, як молитва свята. Щастя, добра і любові, на многі літа. Як літо настане чи осінь, зимою або ж навесні, коли за вікном дощ і сонце, хай будуть щасливими дні. Для вас щастя, добра і любові, щиро бажаємо вам. Щастя, добра і любові, дітям, онукам, батькам. Щастя, добра і любові, звучить, як молитва свята. Щастя, добра і любові, на многі літа. А разом з нами один одному щастя, добра і любові. Щастя, добра і любові, щиро бажаємо вам. Щастя, добра і любові, дітям, онукам, батькам. Щастя, добра і любові, звучить, як молитва свята. Щастя, добра і любові, на многі літа. На многі літа. На многі літа.
Нам дуже хочеться, щоб наш сьогоднішній музичний
We really
дарунок
would like to make sure that this musical gift will become part of your memories and will have special place and colors and shades for the future. We came from Volyn Oblast, which brings together the nature of Volyn, deep traditions, and generous people. And we are happy to thank the organizers for this invitation and this wonderful opportunity to share this warmth and inspiration with each other. With the most sincere wish to each and every one of us in all of the dreams coming true for the better sake of our future, and to finish our ensemble with the anthem of Volyn neighborhood, which was designed by our fellow mate Stepan Krivenki, and may this anthem as a symbol of Volyn neighborhood serve as our true confession of love to our motherland as well as our victorious Ukraine.
для мене став ти піснею, Волинь моя, краса моя, земля моя, сонячна, Волинь моя, краса моя, земля моя, сонячна, шумлять колишуться хліба, як хвиля в морі грається, моя розпічена земля, до сонця усміхається, Волинь моя, краса моя, земля моя, сонячна, Волинь моя, краса моя, земля моя, сонячна.
Де ще знайти таку красу, як в казці намальовану, як нерозплетену косу, до серця причаровану.
Волинь моя, краса моя, земля моя, сонячна, Волинь моя, краса моя, земля моя, сонячна.
Музично-інструментальні вітання сьогодні звучали для вас від гурту з Волині.
Deep
Миттєвості
musical welcome. We're sounding you from Volyn region of Ukraine, from the band named A Fleeting Moments of Life, and hoping for the victory. And please stay safe and care for one another.
Ще обласки!
More and more applause. So, Fleeting Moments of Life. Thank you so much. Thank you so much for such a wonderful presentation. And I don't think that there is any better way to finish up our day. Thank you so much.
Так, ну що ж, пані та панове, на цьому...
Ladies and gentlemen, this is it for today of day one of our conference. We are welcoming you to be here still with us to drink coffee, tea, maybe to have a snack, but mainly network and to discuss what's happening today, prepare for tomorrow, because tomorrow we will be mostly speaking about the scaling up, how to improve, what to change, where to aim to achieve the best result possible. This is going to be tomorrow from 9 in the morning. We are starting our morning coffee at 10 o'clock. We are starting our working days, so don't be late. Better come early. Even more time we'll spend together. Have a wonderful evening, everybody. Have a safe night, and then see you tomorrow. Thank you so much.
Миттєвості життя.